I hope you all slept well and are rested. Thank you for yesterday. I know yesterday was a long day, and we promised today to be shorter. I don't know if it'll be less intense, but we'll definitely try. So the way today is set up is we want to dig into the Access Fund modality in terms of the copay that the Global Fund is providing and what the package looks like, so you have a little bit more clarity on that. We'll also talk about the technical assistance / implementation support that we have available for this early adopter initiative. And then we have a full hour dedicated to monitoring and evaluation, which we think is really critical for understanding the impact of the project that we're trying to do. And then in the afternoon, we'll have breakout discussions. And the intent of the breakout rooms is really to refine the country implementation plan, the demand template, so that we can have clear next steps of when we can actually start procuring and introducing the new platforms in the country. So that's just the outline of what today will look like. Probably going to be a lot more discussion. We encourage you to place questions on the question board or on the table. I think the more questions we get, the more clarity we get. So feel free to keep those questions coming. So to start us off, I would like to call, okay, Amina is still getting ready, but Amina Jaffa is a specialist, a new product introduction specialist at the Global Fund, and she's going to take us through what the Access Fund modality is, and then we'll have a Q&A session right after that. Grania Bridgeton will also talk a little bit about what the technical assistance will look like, and so I think I would like to call both of them to be on the stage so that we can start that session. In the meantime, we printed out some IFUs for the Plus Life platform at the back. So just in case, because I think there were a few questions about it, we have sent around a PDF, but we have a few copies as well in case you would like to take a look. Great. So Amina is here. I'll hand over the mic to her. Thanks.
Good morning, everybody. Why are we all sounding sleepy? It's too early to be sleepy. Good morning, everybody. So yesterday I had promised that I was going to give you a lot more information onto the Access Fund, into what the copay is going to look like. And so I'm here to fulfill my promise. Oh, I don't have a clicker, sorry. Can we please change the slide or a clicker? Okay, we start again. Good morning again. So I'm basically going to talk you through the Access Fund and what it is. So we have a mechanism at the Global Fund called the Next Gen Market Shaping Strategic Initiative. This is a strategic initiative that spans grant cycle 7, so from 2024 to 2026, and basically aims to support introduction of new commodities, as well as scale up of existing commodities. And that is primarily what I work on. The Next Gen SI basically supports introduction of innovations, and for near point of care, our specific objective here is to accelerate implementation as well as support the planning for scale up in GC8 of near point of care tests pending WHO guidance, to basically ensure that we have affordable and accessible molecular diagnostics. We're doing this because we're looking at accelerating access and case dissection. A lot of you spoke yesterday about how this is a very key thing that you're working towards in your countries. And we know that the near point of care test, being small, being portable, is very useful to being able to do that. We also would like to de-risk the early market access and entry for this new supplier. They are new into the market. It is very difficult to enter such an established market, and also to help to diversify the TB landscape, stimulate some sort of competition across the different TB diagnostics that we have at the moment, and potentially drive down the prices to give us some kind of supply security in the future. You will notice that I'm going to speak to you more from a market side than from a health side. So just to bear that in mind, because that is the lens that I use to look at these things. We are also trying to generate some kind of evidence to inform scale. We know that this is the last year of grant cycle 7 for lots of countries. And without having evidence, it's a new product. You've never used it before. If you've never tested it in some of these countries, you can't just immediately scale up. And so how do we support you to be able to do that in a short period of time to help you to ensure that in grant cycle 8, you can really maximize this near point of care test, as well as shaping the markets as well. How are we planning to achieve this? We have two main things that we're planning to do, and I will speak more about the Access Fund. And then Grania will talk to you about the technical assistance that is going to be provided alongside the financial support that comes. So what is the Access Fund? A lot of you were on the webinars that I presented on, I think a month ago. The Access Fund is basically a short-term co-payments mechanism within the NextGen SI. It is used to support introduction of new products where maybe the product is a bit more expensive or there are barriers to access that you may not necessarily be able to afford. It's used for increasing demand to basically drive down price using economies of scale, but also in the case of the near point of care test, where we need to introduce a commodity to generate evidence and recommendations for future scale, where there might not be funding to be able to support that initial introduction. It's a centrally managed pool of funds that is dispersed as a per product co-payment. And it is really determined based on what the product is. We have had 2 prior use cases of the Access Fund. This is our 3rd use case. The first was for ACTs, so diversification of first-line ACTs. The second use case was for the introduction of lenacapavir, and now we're using it for near point of care tests. And it's really only made available to a subset of countries like you that are here today, who have certain readiness, be it programmatic, technical, to be able to support the introduction and scale of such a product. So it's not necessarily offered to all countries, and the duration is usually very time limited, which I will speak to for this particular time. And so why do we want to use the Access Fund? I think I've spoken to some of our objectives, but we know that a lot of the countries here, and as well as Global Fund supported countries in general, are in a very funding constrained time. We've had reprioritization, there is reduced funding for diagnostics, the budgets have reduced, and so there is a limited ability to scale up TB diagnostics in comparison to previous years or even earlier this year from the budget that you had. The Access Fund basically provides that co-payment to help you to provide that catalytic support to make those introductions that you would not necessarily be able to do. And like I mentioned, it's helpful for giving you the early introduction for that generation of evidence. But we know that without that data generation that happens potentially now, we can't really envision a scale in GC8. And so it's better to use this last year, try as much as possible to get that use case where we can, to let you know before you're developing your grants for GC8, what it is that you're looking for. We know that there are monopolies that exist in the TB diagnostic markets, and the Access Fund really is a tool to try and support that market transformation. How do we foster competition in a healthy way? And knowing that you can't afford it right now, there will be no competition if nobody buys it. And also just improving access, trying to drive down cost as much as possible by generating the demand from these first subsets of countries that would be the early adopters. So this is what everybody has been wanting to see. And I know it's a very busy slide, but I will try my best to talk through it point by point. For the Access Fund, we are looking to support near point of care. We know that at the moment, we only have one near point of care test that is currently in, that has ERPD that we can potentially procure. This is the Plus Life mini doc, and it was at the back of the room. And I hope a lot of you have had a chance to look at it, touch it, feel it. It is a very small, very portable device with about a 15 to 35-minute runtime. And we know that it has gotten ERPD approval in July, and we are expecting GDG in November of 2025. We've been working with the manufacturer to understand what capacity looks like. And currently, for the demand that we're able to support now, capacity is not necessarily a constraint. I think one of the key topics that we had yesterday was around the shelf life. So we know that from manufacturing, shelf life of the tests is 13 months. Plus Life have said that they're working on an extended shelf life to about 18 months, which they intend to submit to ERPD for an update in March of 2026. So this should be roughly around the time that countries would be receiving tests. And so hopefully it should be helpful that we're working with a little bit more time, but to just bear in mind that as of today, it is 13 months. We don't know what is going to happen with the stability studies and if they will get that approval to the 18 months. So we're working with 13 months in mind as of today. For the pricing, the Gates Foundation very, very kindly supported the base price. The Gates Foundation very greatly helped with agreeing a base price with Plus Life for the tests and for the machines. So the tests are currently priced at $3.60, with the mini doc being $150 and the Thermalyze being $180 that comes with a 2-year warranty, which is extendable to 4 years by with additional funding. One thing that I want you to note in this pricing is that the price is for just the tests, the equipment. This does not include installation, services, freight, and distribution. So it is just the cost of a test is $370, the cost of the device is $150, and the thermolysis is $180. Now, as the Access Fund, what we are trying to offer, because we know that this is, like I mentioned, resource constrained year, you don't have potentially funding to support all these other things that would come out of your budgets. We are creating, for the purpose of introduction, for early adopters, countries, an all-inclusive price. This all-inclusive price will include the 3 things I just mentioned: the tests, the thermolysis, and the mini doc. But would also have additional components that come with it. These additional components will be the service surcharge. It would be the device surcharges for maintenance. It would also be for international freights. We've also done a rough estimate, and the international freight, sorry to mention, for the first cohort of these early adopters is for air freight. And we know that eventually we will want to make it sea freight, but for early adopters, bearing in mind this short shelf life, would be air freight to maximize our shelf life. Then we have in-country logistics, and this is looking at distribution to the sites, which is why we're asking you for information on where do you want this to go. It would also be inclusive of in-country installation as well as training per site. And I think there was a question on this yesterday, which we've also discussed. So this all-inclusive price of everything, getting these tests to your facility in the area that you would like for it to be, is $6.70 per test. This is the all-inclusive of absolutely everything in what we're calling our Diamond package for now. Diamond Deluxe, sorry, it's not just Diamond, it's Diamond Deluxe package for early adopter countries, considering that we know that we want to maximize introduction as much as we can in this first year. Now, what does that mean for you as a country? The Children Investment Fund Foundation has so kindly given the Global Fund and the Access Fund $14.4 million. This is for the duration of 2026. And with that funding, we've basically been able to develop this access fund to support you with the introduction. We are using an all-inclusive price of 704, and the reason why it has gone up from 670 to 704 is because there are additional procurement service agent fees that we would have to pay to ensure that it gets to you, and that is about 5% of the cost of the tests, which is why we're using a budgeting price of 704. One thing to mention is this is a budgeting price. When we get information from you, the information that we have from your demand templates will be useful for us to inform the conversations that we're going to have with the manufacturer to finalize those prices and be able to say this is what the end price is going to be. But we envision that this price being our ceiling at the moment. What we're asking of countries is $2 of the total amount of our Diamond Deluxe package. And this
Y ese $2 viene para la financiación de la parte de lo que nosotros tenemos el diagnóstico y que nosotros vamos a básicamente tener como una diferencia para poder como apoyarle en la introducción. ¿Por qué $2? Nosotros estamos dando esos $2 porque tenemos como en ese momento una conversación para una
price per tests come mid-2027. Or after the procurement of 7 million tests, whichever one comes first. And so this is taking the price as close as possible to what it would be for you, with us being able to maximize what we can support with in this first year. We are also offering a bundling approach for the procurement of the tests. And this bundling approach that we've shared with you before you came here is specifically to Plus Life, just to mention that. And I will show you what the bundles look like. But I think we've said so many times that the bundles are indicative. They are for planning purposes, they are for illustrative purposes to give you an idea of what it is that the bundles could look like, for you to plan where you want to put it, have an idea of how you would like to place it, and more to be a guide. But we really are open to your suggestions on how those bundles can be improved, because the feedback from here is going to help us to do that. The eligibility is all of the 13 countries online and in the room. And there are some conditions for access of getting these funding. The first is you agree that you're willing to pay the $2 of the price per test. The second is that there is some sort of a commitment towards including near point of care. Here, I did not say Plus Life, I said near point of care as a class within your grant budgets for GC8, because we know that there are additional suppliers, manufacturers that will come into the market within the next year or two. And so we do not want to create a Plus Life monopoly while we're trying to destabilize the market already. So your budget line, we would ideally want a near point of care line within your grant budgets in GC8. We've spoken a lot about registration. A lot of you spoke about registration and how long it takes. So some form of a commitment to fast track registration or an agreement for an import waiver of sorts. This is bearing in mind also shelf life. The 13 months is not as much as we think it is. That is from point of manufacturing. If it gets to you and there's 6 months left is not as useful. So really thinking about how do we fast track implementation so that you have enough time as well to also implement and to test these within the country. And then also to utilize the access fund, procurement has to be done through WAMBO, because that is the only way we can co-pay the amounts that we're offering. So you've seen this. This was shared with you as part of the packages. It is, I think, the slide that is included within, or the picture and image that is included within the demand template. These are the current bundles that we are suggesting. And we're suggesting the first bundle for a more decentralized setting where there are 2 mini docs, 1,000 tests with 1 thermolysis machine as well as a battery pack. The second bundle has 3 mini docs, 1,500 tests, a thermolysis machine. This we're looking at more for microscopy or treatment sites. And then the third is where there are 4+ life mini docs, 2,000 tests, and 2 thermolysis machines. And this is more for higher volume sites. I will say one more time, there is nowhere where I'm saying that this is the bundle that you have to choose. This is the design of the bundle. This is written in stone. If today you tell me, Amina, I hate this bundle, give me something that has less tests, 1 mini doc, less tests, this makes more sense. It helps me to have an idea of what it is that you actually need. So in your breakout group sessions, I really, encourage, discuss it. Tell us what makes sense for the settings, for the areas that you're thinking about, how you want to implement it. If this works as well, tell me, yes, it's great, I like it. And that also is helpful for me to understand what needs to go into our next set of conversations with the manufacturer to determine what the best bundling approach would be to make it easy. Mo also mentioned yesterday, a bundling approach does not mean that it's going to be delivered to you as a prepackaged bundle. We know that we have the shelf life constraints, so you will most likely get your machines in advance and then your tests would come later. So it's not like it's coming as a package, but it helps to create the package to have a better pricing deal, as well as also to understand where you want to place it and how it will be utilized for your different settings. This is not going. Okay, so this is, I think, my final slide before I hand over to Grania. Just want to kind of summarize where we're at. I think before you came here today or this week, you would have received an email that had what the current allocation is to your country. This is based off of what the available funding is from the Access Fund, as well as the TB notifications for your country as a percentage of the cohorts that we have in these 13 early adopter countries. I'm going to ask that you build on your presentations, build on your group work to really look at that demand template, update it as best as possible with the information that you need, when you want items, how you want them placed, what bundles you're thinking about, because all of this information is important for us for our final negotiations with the manufacturer to come up with the final package, final price, final bundles. It's also important for us to then tell you what the total test volumes that we can offer is. And that is what is going to be communicated to you in an official offer letter from the Global Fund saying Global Fund is going to support you through the Access Fund for XX number of tests for the period of 2026. So in terms of the process of what happens is once we finish today, you share, we will do all our background work to try and get the final numbers, final costings, and then you will receive an offer letter. The offer letter, like I mentioned, will have the total number of tests that you would be offered, as well as the conditions that I had listed previously around willingness to pay your $2 per test, the waivers for fast tracking waivers, use of WAMBO, and sustainability of some form of inclusion within GC8 for near point of care as a class and not for Plus Life specifically as a product. And then once we receive your acceptance of the offer, we would then expect from you a final demand or supply template with your indicative timelines. We would then ask that the principal recipients for your country would make the request for, or the principal recipients for this disease area for your country would make the request for the agreed number of tests. If you do not have a PR, there will be an onboarding. I think everybody here should have a TB PR, but if there is not one, there will be an onboarding process that would also come along with that. And then the order process will go as per usual, with $2 being taken from the grants in the budget line that is for diagnostics or under TB that you've identified as where you want to charge. And then the rest of the costs would come from the Access Fund separately that would cover everything up until your in-country delivery costs and the trainings in installation and trainings. And then we go to order delivery and hopefully implementation, where you actually get to use this in your settings. I think I'll hand over to Grania now for one slide and then we'll take questions.
Everyone, build on that as well from the demand estimation, as Amina said, you do get an indicative volume. As part of that process, you can feed back to us on if you feel that you can absorb that volume within the time frame. So this is for 2026, so it is a short time frame. So it has to sort of be ordered and arrived in country within 2026. So this is why we've been asking about the sort of timelines of process, because we don't want any products going to waste. So if you don't think you can absorb your allocation, that's not a problem. You can sort of let us know what allocation you can absorb. And the flip side of that is that also if you would like more, and I think some of the presentations, yes, so were very bold, be clear on what you want so that if there are additional tests available, we can reallocate. Great, so I'm going to be very quick and leave plenty of time for Q&A. Just a quick overview on the TA process. Global Fund will be working very closely with the CIF team on the TA, and there's a number of components to it. So every early adopter country will have the opportunity to have an embedded consultant within your NTP, because I think we see that this is an extra piece of work that has arrived with a very short timeline, and there are a number of other things. You're busy implementing the final year of your grant as well, and it's also a funding request year. So to bring in anything new in this kind of very pressurized time, it may be helpful that there is someone really dedicated to drive it forward and work closely with you and the relevant partners and stakeholders. I think that's also what came out very strongly yesterday, is that this may be a TB tool, but there's a lot of cross-linkage with the regulators, with the TB program, with your communities, and regulators, and the lab directorate. So having a focal point based in country to really help make sure that everyone is pulling together and moving this forward. We will share with you after the meeting, and those of you who've been in Global Fund SI projects before, you'll be slightly aware of our terms of reference template. So we will share a terms of reference template. We are not seeing this like some of our other sort of TB SI, where it's a short duration. They come in, they do a guideline update and they leave. I think we see this will be sort of a 12-month contract where it would be based within your program, and they could potentially, with the tools that Patricia was saying that will be coming with the guidelines, sort of take them, adapt them to your context and implement them and follow them up in country. So, and we will share the draft template, and really this is an opportunity of what kind of work do you think this person, is it a very M&E focused? Is it very sort of just project management focused? Is it, and so have a think to, the template will be generic and you can refine it as to what you think you need within the program. Then similar to the SI processes that we've done before, we will agree the terms of reference with yourself, the country team, and then there will be some feedback from CIF as well, as to make sort of agree that this is likely for success. Then there's an opportunity for you to nominate if there is someone that whose profile you think fits and matches this terms of reference. You can nominate 1 or 2 people, share their CV. If you would like to have an opportunity to tap into some of our technical partners, TA consultant pools, where they're to kind of see if there's other consultants, people available who would be potentially a good fit for this, that too we can offer. So that's kind of, and then we'll get on with the recruitment process. We like tight timelines, and we also know there's a lot of work to be done. So I think we would be working with you and your country teams to see if we can get this TA process finalized and ideally recruited by the end of the year. So come January, you have the right resource in your program to really help do all the preparatory work before the product arrives in country. So that's the plan for that. Then sort of this will be linking with a specific focal point at the Global Funds Secretariat, who will be feeding into working with SIF, our partners, the country teams, and the consultants in your countries. There's an additional third-party TA that is, which will have the potential to either offer additional support to focus countries, or if there's, and I think that's why yesterday we were very much wanting to collect a kind of wish list. Now, we cannot guarantee that all the TA that you think you need would be, we would be able to support, but that's going to be very helpful as we work out how this third party TA to sort of can potentially help fill some of those gaps that the more embedded TA would not be able to work with, or is sort of too specialized for that more generalized post. And then there will be an additional floating consultant, and this is kind of probably more linking, as I was saying yesterday, your work and your experiences and your innovative ways that you're going to overcome the challenges, because we know this is going to have challenges, to other countries, other Global Fund supported countries in your regions or outside your regions who are wanting to scale up the near point of care tests in GC8. And so really facilitating that learning, that that sort of experience sharing. So I'm being very positive this morning so that your success becomes your region's success. So that role is going to really be helping link your work to the broader opportunities for other countries within GC8, where there is the new funding request. So they'll be working with you potentially sort of, and the embedded consultant and the partners taking your experience and helping drive success generally. So that's all for the TA. But as I said, the sort of main thing we'll be working on a lot with you in the next month, because we're good with tight timelines, will be getting that embedded TA organized and arranged so that it's ready for you in ideally January the 1st, 2026. Thank you.
Thank you so much, Grania and Amina. I think we'll open it up to questions. Feel free to raise your hand if you prefer to jot it down on a paper. Dr. Taye, you can go first.
Thank you very much. Thank you, Amina and Grania, for great information. Maybe I need some clarification in 3 areas. The first one is related to that of the registration. In some countries, there is a rule and regulation that need the local agent to be registered in a country. So is there any plan? Is there any plan that allocated or local agent in a country, especially for the early adopter countries? That is my first question. The second question is related to
Go ahead.
the second question is related to the co-finance. Yes, co-financing is very important because as there is some co-financing process, and recently, as you know, due to the reduction of the global donors, most of the financing part is moving to the government. So is this co-financing, especially for the procurement of the material, is using in country, or it is also used for the procurement of the tools? So that is the second question. And third one is maybe related to the bundle. So I'm not sure that maybe I'm confused because if one machine mini doc is completing one test within 15 to 35 minutes, and the one health facility is testing more than thousand. Why we need 2 or 3 mini dogs per health facility? Because even one can be many tests per year. It is more than conduct more than 1,000 of or 2,000 of tests as the test is completed within 15 to 35 minutes. Thank you.
Thank you. Should we take, would you like to answer immediately? Okay, we'll get 2 more and okay, so Dr. Stephen and Prof. Njeka.
Thank you very much for the presentation. My question is regarding the first presentation and the bundles that were presented. So looking at this bundle, I don't see one that fits or suits the community properly, because from our experience in the community active case finding, you are faced with multitudes sometimes, lots of people. And there's one particular type of doc that is not presented here, the 8-in-1 doc. So that is the doc that we use for our community. And sometimes we even add other docs just to make sure that we meet up with the high demand. And of course, I agree with his question also regarding the numbers in the facility. For the projection of the mini docs per whether 1,000, 1,005 or 2,000 burden facility with people, we have to really calculate carefully. Otherwise, we find ourselves in a situation where the docs cannot meet up with the numbers. So this is my question, and yeah.
Okay.
Thank you so much for a wonderful presentation. I think it was really good. The summary in the morning made a lot of sense. Maybe just to remark, we're studying GC7. We just a few days into GC7. I saw your slides, you put GC8. I understand everyone is ahead of us, but I think probably it's important to remark as well that there are people who are, behind schedule and all that. But the question really I have and the comment is around the co-payment. I see it looks good, cost to country. So now my understanding is that we'll have additional funds, and then we'll be using current allocation to do this project. Obviously, one then says that the domestic fund should fit in somewhere. I'm not too sure, because for sustainability, maybe you need to give us some advice on how do we do this, because also in the communication is really critical. One of the things that has happened to many countries, including South Africa, is the fact that you'll allocate TB funds in the provinces to equitable share, but then you give them opportunity to access additional money from national treasury and from partners. And because of the bureaucracy of accessing government funds in most countries in our region, especially, people access donor funding, partners' money. Domestic funds are not utilized. So financial people understand that language where when you don't spend, or when you underspend, they cut your budget year in, year out. So when you talk to leaders in countries about this program, you must fit somewhere that we're studying this way, but sustainability, there must be a role of domestic funding, so that those people who have a habit of underspending domestic funds because there's additional funding from somewhere should really start behaving, because we have problems now due to that kind of behavior. So maybe if we could look at something around that, it would be very good. But also, is there a mechanism to begin thinking about the price in future? I mean, look at us. We use GeneXpert for so many years, but I've not seen significant reduction in terms of the money we spend for GeneXpert. We bring in Roche machine, BD Max, but as a manager of the program, I'm not satisfied with the price reduction. I think, I mean, if somebody has done 26 million tests like us in this, we're planning 5 million a year. We can do 10 million. I mean, for us to end TB, we should do 10 million a year. I know most people don't believe, they think I'm crazy. I didn't smoke anything. We should do 10 million. A country like Sarawak, you need to do 10 million, but you can't do 10 million in an environment where you spend $12 for one test, one person. We need more cheaper options. We need also assurance that if we really do this well, we pick up with numbers, we will see like real-time price reductions or adjustment because we also don't want them to go bankrupt. But I don't know the future. When we start talking domestic funding, they'll be asking what happens after 5 years. Will it be like the old tests which don't reduce where the price remain the same? So I think that's critical. But the last issue also is quality control. I'm not sure what precautions are we going to take for quality control, because I know in many countries, even us, you don't have a lot of, you actually don't have lab qualified staff, or maybe you have one, and quality control becomes difficult. Urine lab is just an example. We introduced it some years ago and was really struggling with quality control. And so I hope that we also think about it. So I don't know whether I'm complicating your lives, but you can see from the questions, this is someone who's really wanting to use. And I think if we work on this, probably it would be easy to convince people at home. So we need to use this because healthcare workers, doctors, nurses will have to embrace this for it to work. We can't afford to bring pathologists and highly qualified lab guys to those places. But the guys who already work need to buy in and assist us. So those are my few comments and questions. Thank you so much.
Thank you.
So lots of very, very great questions. The first one I think I will go with is on the local agent. I believe that Plus Life is working to engage local agents within each of the countries. We have shared with them the list of the early adopter countries that are here and that we plan to work with now. And so they're working towards engaging, and I believe they may have already done so in majority of the countries that are in this room. I think there may be one or two that they're yet to engage somebody there. And those local agents are basically going to be there to support as much as possible with the services. So one thing that I think I failed to mention in my presentation is that the approach for Plus Life is not a servicing and maintenance approach. It is a replacement approach. So if a mini doc stops working, they take it away and they give you a new one. And so that is part of the rules and part of the services that we're paying for within this package, is to have those, and why they have the local agents. So if there is an issue, they take it away, they give you a new one. So there are local agents, and then they will play roles with supporting the country. The question you had asked around co-financing and if it's for the other country costs or just the products cost, at the moment, we're focusing just on the list that I showed. So it is for the tools themselves and the service and maintenance. And then there is that one line for the in-country distribution, as well as the training of on site on how to use it. That is currently what this current package covers. We have not included additional costs for other implementation related support. And so that $2 copay will just cover these things of delivering the tools and the introduction, installation and training in those sites. And then you had asked about, cannot read my own handwriting. Yes, the number of mini docs per facility. So the way that the bundles, and this kind of answers both questions, the way we had envisioned these bundles is, for some settings, I understand that it might seem a lot to have 2 mini docs and 1,000 tests if you're not running as many tests. But if the mini doc fails in a rural setting, you want to have a second mini doc while that other one is being taken away to be replaced. You don't want to just stop service provision or stop being able to test, which is why we are offering multiples so that you have at least a spare in your package in that facility. For the 8 dock, we understand that it is being used currently for testing. However, it was not part of the equipment that was submitted for ERPD, and Global Fund can only procure ERPD'd products. Plus Life is planning to add it to its additional submissions in March of next year. And so for now, I cannot consider it as part of my package because it does not have any approval for procurement. And so I will only work on what has ERPD for now. On the question around, we understand that we know that there are countries that have different grant cycles. I'm very aware that South Africa is special in this case, being very new to grant cycle 7. The Access Fund, however, is linked to the traditional grant cycle, which is why I'm using the language of GC7, GC8, because it is linked to the 2024 to 2026 cycle. And so the support is linked to that current time frame, but completely understand that there is, nuances for certain countries. There would be a nuance for South Africa in asking that it be included maybe in your GC7 if I'm an Oliver Twist. If you see that it works greatly in the next year, maybe you add it towards the end and you see there is something you want to continue to procure. For domestic financing, you are preaching to the converted. I think that it's very important that countries definitely consider domestic financing and continued procurement of this. The intended supports right now, we know that this is a new product. There is only so much that we can do within the available funding. Currently funding is not a topic that people like to talk about because it has really been cut down on across the entire board. And so the intention is if there is opportunities for domestic funding for additional procurement, we will greatly appreciate that from countries. I believe one country that is currently really looking at this is Indonesia. And this is also an opportunity to talk to and learn from each other. And maybe, we can speak to our Indonesian colleagues on how they're looking at this because they have started this conversation. So definitely something that we advocate for. For future pricing, everything you said around the experts, around the pricing of the expert not changing over the last few years is really one of the reasons in a market shaping perspective or using a market shaping lens is why we want this first in class to succeed. Because if Plus Life does not succeed, other manufacturers who come in after will not have a market to come to and will not have an incentive to want to continue. And so we currently have a diagnostic, somewhat of a monopoly, which is also why those prices don't necessarily change. But this is in no way saying that the near point of care is a replacement for what the gene expert can do, but it gives us additional options. And these options help to then create that space. And from the beginning of day one for this new near point of care test, the conversation has been around how do we ensure that the pricing does not remain the same for the entirety of its plan, which is why I had mentioned we have already started those conversations around 2027, having a reduced price to $2.50 from $3.60 per test. We understand that the fiscal space is consistently shrinking, and if we continue at the prices and at the amounts that we have today, we're going to only test less and less people. And so we're trying to really support the market as much as possible. And this is also part of, I guess, the reasons why the Access Fund needs to happen now. Because if it happens now, countries can start to procure now. It sends a signal to other manufacturers who are working to come in 2027 that this is a market that is viable, there is demand, and potentially other expansion is going to happen and scale up as we go further into the next few years. For quality control, we are, I think at the moment, this is something that we had discussed yesterday, and there is different, I would say, post-market surveillance type of guidelines for each country. I think this is something that we also wanted to flag for the group discussions, the breakout sessions, is what is required in your countries to help us kind of understand. We are still having conversations with plus life around what they see for post-market surveillance, what they want to do for quality controlling. And I think this is something that we definitely take serious. Patricia also made a comment to this effect at the end of yesterday's convening. And I think it's something that we are still working towards. This is new. This is literally like, it's only been viable for procurement maybe 3 months now. So there is still a lot of things that are happening behind the scenes to get us to the point where we can give you all of this information. But having an idea of what your quality control systems, what your post-market surveillance systems look like in each of your countries helps us to understand what do we need to make work for implementation. Grania, do you want to add anything?
Thank you. Just a few, you covered most of them. I think the other consideration on the bundle around maybe the lower bundles still having too many docs is the understanding that TB testing doesn't necessarily flow in a straight line all over the week. You'll have your Monday OPD, maybe that has a sort of, so it's to allow for surge, to keep that turnaround time down. And because the average utilization is, you know, we're not necessarily expecting a decentralized test to be running at 100% capacity, whereas our more expensive low complexity NAT platforms, we do expect a much higher utilization rate. This is going down to a lower level of care, but also trying to reflect a little bit of Stephen's comment of like, there will be surges, there will be days where you're doing quite a lot more tests. And so having too many docs available, they may sit unused on a Friday afternoon, but on a Monday morning, they may be working quite hard. So that's some of the operational flexibility that we've been trying to embed into these approaches. But as we keep saying, feedback to us if that sounds about right to you or not. And I think the community, because we cannot procure the Doc 8, the community screening, and I think that's just getting a sense from yesterday, sort of how many sites, and maybe that approach is something that is, as we go through your implementation plans, either that happens towards the end of the year where we may be able, pending either WHO PQ processes, because that is running in parallel to our existing ERPD approval, for that doc that can run 8 tests at the same time. So really those community screenings where you're suddenly doing a lot more people and then you aren't doing an awful lot. So yeah, so that's and then what else was I going to say? I've forgotten. I did have a final comment, but I
just on that last point of multiple mini docs, I think to avoid interruption, it's always good to have doubled or multiple. So my concern is, why do we have one thermalizer and one battery in that bundle one? Given that they are able, since these things are going in the rural area, there could be an interruption of service. My recommendation really is really have them double. We tried the one module expert. It didn't work that very well, because when it goes down, you are in trouble. So my recommendation is to double. The other one is actually involvement of NTRLs. It is very common for simple tools like this to bypass the National TB Reference Laboratory, and you don't put an instrument there. But talking about each way, talking about supervision, that will be an oversight. I think this Pulse Life makes sure that every National TB Reference Laboratory is capacitated and has equipment. And actually that will solve very many of the problems we are talking about. The issue of local agent, much as you say, the equipment servicing may not be necessary, but I'm really rethinking. I know probably you haven't thought about private sector. How will they, where will they procure their units? I think you need a local, maybe a regional distributor somehow, where somebody goes in and buys their equipment. And in terms of local funding, this is really low-hanging fruit. There is people who are willing to help us fund this. So we need to tap into those resources, but make sure a local agent is available to buy and even replace. You need a stock of mini docks and supplies in the country to help. Of course, I haven't had a comment from the users. There's people who have been using. How robust is the mini dock and all thermalizer? If I take it on a bumpy road in Uganda for 10 hours as I drive it, it is still robust, or do I need to calibrate it first or to validate it first? Let me stop here for now. Thank you.
Thank you. All very good questions. We have Abdul Nur here. And I'll maybe call on Melissa and Dr. Stephen, who have been implementing, to comment on the robustness of the platforms, if you could. Go ahead.
So thank you. Our main is on TA. As you mentioned, our TA needs are quite broad, but just to clarify, what's the maximum number each country can have at a go?
Okay. Do we have one more question from the room? Yes, Janet.
You did mention that WHO approval is expected next month, but should that delay, will the PRs be required to get the QA approval now that the product is still ERPD approved? And can we perhaps get a blanket approval for all the early adopter countries?
Okay. Okay. Sorry to put you on the spot, but Melissa, Sanders, or Stephen, do you have any comment around the robustness of these platforms? Just give that mic.
Thank you. I think we've done a few thousand tests on about 8 platforms, and we haven't had any problems with the mini doc, but those are small numbers. And I think Professor Jalova's point about having 2 of the mini doc and the thermalice, because the equipment is so inexpensive, and if we're going to put all the energy into getting the devices to the sites, having 2 of each could be a good plan to make sure we don't go without testing.
Okay.
Thank you, Melissa. I think the equipment is robust. The only problem we had is with there's a noise reduction seal on the thermalizer. After you used it for a long time, the vibration, it starts like getting like out of where it is. So you start hearing more noise like that. So, but as you said, it's a replacement kind of thing. So of course, everything has its own lifespan. So we have one of the thermalizers that have that issue only, but regarding movement, bumps and humps, gallops, all this, there's no problem at all. It's a very robust equipment. Thank you.
Thank you. Yeah. Patricia, go ahead.
Thanks. Just on the WHO process side of things, just for clarification and to make sure that everyone is clear on the timelines and what to expect. Our systematic reviews for policy assessment are still ongoing. So we don't have the final reports from the systematic review teams. That evidence will be reviewed next month. That's correct. But it will be early next year before the policy statement is released. So that will come either in the form of a rapid communication or as a newly issued consolidated guideline. So we are believe the product has promise, but we cannot say at this time whether or not the product will be recommended by WHO because we have to go through the process. So when today we're talking about it as first in class, we don't actually know that yet. We're assessing it currently to see whether or not it will be first in class. However, the parallel process, the open for pre-qualification, is happening in parallel. And so for the quality assurance side of things, for manufacturing and safety, our understanding is that that will be moving forward at the same time. So our hope is that at the time that this rapid communication or that the consolidated guideline is released, then we would also be speeding the pre-qualification so that it could cover after ERPD potentially. So it depends on the timelines that the company moves with pre-qualification. So we don't have an estimated timeline for completion of that process.
Grania.
Professor Jaloba, you reminded me of the thing that I was going to bring up, which was exactly what you said about the quality control and including the TB reference labs and the TB labs in the lab directorates in your countries. And I think that is why we have always endeavored to have the lab focal points or the lab directorates involved in these conversations, because it's really important for just generally everyone knowing what is available in country, so that these, and because sort of some of these tools do have multi-disease capacities, and so it's important that both the lab knows what the TB program is up to and the TB program knows what the lab program is up to. So and on the quality control thing, I think one of the things that we have been talking to the company about is putting a quality control test in every box of 10, because that isn't currently the situation. But again, this is we're your intermediary to the company. So you tell us what is needed for your context and your programs so that we can really try and get that for you. For the TA, we are only going to be offering sort of one embedded consultant. There is an additional technical partner that is likely going to be available to support either particular countries or particular areas. And I think that's why we're trying to gather from you exactly kind of what your needs and wants are, with the caveat that I'm going to give you no guarantees we can address all of that. But I think what we can guarantee is that there will be an opportunity for you to work with your Global Fund country team and the Global Fund Secretariat and SIF on the terms of reference for a person embedded within your program. We're presuming probably the TB program, but if it needs to be embedded within the lab directorate, as that's where the biggest gap is, then we can work with you on what your needs are for how you'd like to use that opportunity of a 12-month embedded sort of consultant that is co-managed by yourselves and the Global Fund. So, and then for the ERPD and the procurement process. So I think just to say, the Plus Life mini doc got ERPD approval, not as a near point of care test, but as a NAT technology and it's got approval for use of a sputum sample, this case swab in sputum sample on a NAT technology, and it sort of and it was eligible and went through the ERPD process as a low complexity NAT, of which there is WHO guidance. Now, I think what the WHO guidance process, and Patricia will correct me as appropriate, is that defining of what that that near point of care class is, in which case then does the Plus Life mini doc and thermal analysis machine fulfill the criteria of that class, and then it would be the first in class of that. But actually, from the Global Fund ERPD approval and ability for Global Fund to procure it, it's a low complexity NAT that has sputum as a sample. Now, the other thing that the WHO Guideline Review Committee is also reviewing is this new sampling technique for TB, so the tongue swab, and it's looking at evidence, again, Patricia, but in the tongue swab in a number of platforms, low complexity automated NAT platforms and near point of care class ones as well. So that bit is entirely new. And so that is the ERPD approval. And if you see the IFU on the table is for sort of sputum, but there is the potential that in 2026 you can use tongue swab. So that's sort of as you're thinking about your algorithms, your workflow, your SOPs, your trainings, that sort of pending WHO guidance, you may want to think about who would you offer tongue swab. And if you saw on the first webinar, it is much more sensitive in sputum, and that may be the approach of get sputum where you can, because it may be it's more accurate. And then if it is a positive plus life, you don't have to go back to get a sputum sample to send to your low complexity NAT or your centralized system in the case of South Africa, because you already have your patient interaction as one. But those are conversations that will be guided from what comes out of the guideline development group and from your own internal technical working groups as to how you see tongue swabs. But from a sort of you putting an order into Wambo, we can procure it now. It's kind of slightly independent of the GDG process because we've approved it as an existing class, and there is a WHO guidance of the use of low complexity NAT on sputum samples. So we're hoping that's kind of one of our workarounds, and then that's sort of where we're all going to work together to find out how we can. But I do know that WHO PQ in some contexts will facilitate things even more than an ERPD process. And so that is why we feel it's very important that, and this is why ERPD is a stepping stone to a PQ process. Yeah, I think that is all. And Patricia, you can correct or anything. Perfect. And if I miss anything?
No, I think the only question we didn't get to was around a regional distribution. Around private sector engagement. I think that's a conversation that we can continue. But more, did you
They need a microphone.
Yeah.
I think it's important for the audience, yeah. So just to try to help wrap up this very helpful conversation in your minds, what is the offer here? Okay, you're being offered access, early access, and accelerated access, and I underline accelerated, okay, to a product that has a use case within your diagnostic algorithm, and that has a potential in the future to offer you access to a different type of samples that could have a differentiated use case for other populations. Okay, so that's sort of the product that you're getting access to, and whether it's an LC NAT or whether it's a new point of care that is being now in the process of the systematic review. And I think Grania's and Patricia's point were very clear on this. Now, with that offer that you're getting it at a really reduced price, okay? Considering what Amina mentioned of the inclusion of the items in the package, you're getting only $2 on the grant for all these, the product, the test, the platforms, and all the maintenance and service and distribution trainings, etc. Now, when you get that, you have to also expect that there will be a commitment from the countryside. And I think that's very important to put it in the mind and to put it out there. What's the commitment? The commitment, the first one is that you really want to be an early adopter. You are ambitious and you want to do it within the implementation timeline that we are talking about here, which we are bound by the available funding to implement within. So you have to know that it is within 2026, that if you are coming to this initiative and you would like to receive the product at this price, you'll have to be ambitious in terms of your implementation timelines. Get the product in the country before the end of 2026. Ideally, it should be in the Q2 or Q3, and so that you can start the implementation, right? So this is the first sort of commitment that you all will have to be clear on when you go back and you speak to your seniors in the country. Now, the second thing is that there is a budget commitment. You will have to budget from your grants at least the $2 for the product, but also the costs that are related to the non-product costs. So any trainings that you need on top of what the supplier is providing, you'll have to budget for this. Any kind of meetings, workshops for the guideline and policy development process, this will all have to be budgeted, bearing in mind the prioritization and the constraints that are existing on the budgets itself. This is the second thing that you have to be clear on, that it will have to be budgeted, have to be available, because we want this to be a success. We don't want the products to come with a shorter shelf life. They are there, we'll have a waste, we'll have an expiry. All of these are risks that you don't want, we don't want, okay? The third thing here is that there will be some additional sort of commitments related to aligning with that ambitious and accelerated implementation timeline. And these are basically the regulatory process, your own country process related to registration. We'll obviously work with the supplier to get the registrations on time in terms of filing, but the decision is a country sovereign decision. You will have to make this decision and you'll have your own timelines. And you in the NTPs and in the ministry will have to have these conversations with your regulatory authorities to actually tell them, we want this product by this time so that we start the implementation. And if we can't get us a waiver, at least for the first shipments, if the timeline for registration will go beyond what we are having here as an implementation timeline, then we'll have to be very clear on this from the beginning. Because the whole point of engaging early with countries on this is to actually pre-plan it to be a successful introduction. And rather than trying to see hiccups, trying to do it without having that and have hiccups in the process later on. So I think these things have to be very clear to each and everyone in the room. Obviously, there were communications about it, but I think with the discussion now gearing towards, okay, what are the next steps? And getting the offer letter, accepting the offer letter, accepting to go through the procurement process and the procurement platform that we have with Wambo. All of these are things that you'll have to be clear. These will come as commitments from your side if you choose to engage in this initiative, which I believe, since you have committed to come here, you actually want that. So just sort of to wrap this in your minds of what is offered and what is also expected. Thank you.
Thank you so much. And very cautious of time, so I think we might need to quickly move on to the M&E session. And this session will be chaired by Michael from ASLM. So I'd like to introduce you and then you can take over. Thank you. Thank you all.
Thank you so very much. Good morning, ladies and gentlemen. Good morning, ladies and gentlemen. My name is Michael. I work with the ASLM. I see a number of my colleagues here. Dr. Collins, please wave. Lucy, please wave. Francis is here too, please wave. Caroline, who is walking around, please wave. And as Melanie was speaking earlier today, she mentioned that we would want to end early today, and I see the program ends at 5 o'clock. There is another program that she has not given you that starts from 5, because I'm from Kenya. I would want you to get out there and help strengthen our economy. So please, if you need any help moving around the country, please get in touch with me. I'll be able to facilitate now that I come from here. We are getting the discussion on M&E.
yesterday, listening to the country teams make their presentation on the plan, on where they intend to, the site selection, the budget, the indicators. It was extremely informative. And as we get into the discussion today, we have a number of presentations that will be made today for the next 1 hour. I would want you at the back of your mind to have 4 questions. 4 questions. The first question, now that we have discussed about the indicators, we have talked about the sites. The first question we need to ask ourselves is, where will the data live in your country? Where will that data be? Are we together? Ask yourself that question. The second question that I would want us to have at the back of our mind as we get into this discussion will be, how do we get that data there in the most efficient way without necessarily basically relying in the current existing systems? And of course, the decision that you make with the data depend on the quality of the data itself. So you'd want to ask yourself, how do I ensure that the data is of good quality? And you know the dimension of quality, timely reporting, for example, the accuracy of that data. And finally, number 4, we don't want to collect data for the sake of collecting it. Collect, and forgive my R and Ls, I get them mixed up. So I don't want to correct data for the purpose of correcting it. So you have to ask yourself, to what extent are we using these data for action? So those 4 questions. So we are going to have a number of presentations today. We have Namdi, who is going to make a presentation briefly on the essential programmatic indicators. He'll be joining us online, and I believe he is almost ready. And then after that, we're going to have some country experience first from Uganda. Nyombi will be doing that, and will be joined online again by Nuru, who will be making a presentation. And after that, we're going to go to the panel discussion. So without further ado, I would want to invite Namdi, I hope I'm pronouncing the name correctly, to make his presentation. If you can hear me, please let me know you can hear me. Is he online? All right, let's give him a minute. So as we hit, oh, there you go. All right, thank you so much, Dr. Mnandi. Please go ahead. All right. As we wait for him to get online and as we wait to get technology working, remember the 4 questions. Where will the data live? How do we get it there? How do we ensure the quality of that data? And how are we going to use that data for action? Those are the 4 questions that we need to answer today. To have at the back of our mind for every one of the countries, think of those 4 questions.
Good morning. Can you hear me?
Perfect. Good morning.
Yeah, morning. Sorry for the small delay. Good morning, colleagues, and thanks for having me in this session. Greetings from Geneva. My presentation is really going to focus, and in fact, not just my presentation, the subsequent discussions and presentation that would follow is aimed at just reiterating one of the important things that we all know and have been discussing, including yesterday when this country spotlights were being made, and that's M&E. It's critical that as we go on this journey, we continue to ensure that everything related to the monitoring and evaluation of this and the use of the data is paramount during implementation of the early adoption and the scale up subsequently. Next slide, please. Can someone move the slide for me? 'Cause, 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 Thank you. So, as I said, we put a lot of emphasis on the actual implementation. But one thing is important, that without understanding what the data is saying and where we are in terms of monitoring the scale up, it will be challenging for anyone to achieve success. Some of the benefits of ensuring that we have a strong M&E system during the scale up of these NPOCs are, firstly, tracking coverage and uptake of the NPOCs. It helps you monitor how widely and effectively the test is being used across sites. Another reason is identifying bottlenecks, because with the M&E, it serves as an early trigger. You know, if a site is not reporting, what are the challenges there? Something is wrong. Why are we not seeing reports on time from X facility? Are there issues with sample transportation? Are there issues with the supply chain? Are there quality-related issues? This helps identify these implementation bottlenecks. Another is, of course, support data-driven decision-making. This is always paramount. And it helps you know, do we need to move a particular device? Are there issues around staffing from a particular place? Are there issues around allocation of the devices to a particular site? And then it also helps to facilitate accountability to the Ministry of Health and National Program, and also to the donors. That also M&E or the implementation would also generate lessons that would help with future scale-up strategy and help guide it. And this is very important, because a lot of times operational feasibility insight, you would only get it based on the knowledge that you gain from field experience. Cost effectiveness of interventions and just readiness for expansion are things that this would also provide. And lastly, helps you measure programmatic performance. I think this one is every day, the actual outcome of the test, you know, how many cases are being tested, what is the positivity rate in these facilities, and of course, operational issues like turnaround time and so on. So broadly, the M&E indicators can be divided into programmatic indicators and operational level indicators. My presentation today will focus on the programmatic indicators. The subsequent presentation will touch more on the operational indicators. Next slide. Thank you. And so I want to start by giving some high-level premise. The scope and selection of indicators and what you are able to do depends a lot on what type of system is prevalent at the country. If you have a full digital-based system in a country, be it aggregate and case-based, it becomes easy to modify, customize, or utilize your existing tool. And then, of course, you know, there will be more timely reporting of the key indicators. So it's much easier. If a country has a hybrid system where paper-based reporting is used in addition to the digital health information system, of course, it's not as full-blown as, the benefits are not as much as a fully digital system, but we recognize that a lot of countries have a hybrid system. And of course, if it's strictly paper-based, it becomes a bit more challenging. But here are some of the indicators that we would need to prioritize when monitoring the NPFC scale-up. The first is demographic data. Of course, this is name, age, and gender and sex. So this provides insight to what the patterns are amongst these key demographics. And then the type of facility. Is it a microscopy site that this result is coming from? Is it a primary healthcare facility? And then the others can be grouped as others. And when we say others, it could include a mobile van, for instance, if they plan to use this NPOC for community outreach in conjunction with a gene expert or TrueNAT machine in a particular mobile van, for instance. that can be classified under other, or if for any reason it's taken beyond the primary healthcare facility for use, that can be grouped under. The next is how many tests are being conducted, how many NPOC tests. So it's the number of tests conducted. And of course, this links to the other, which is the type of sample tested, whether it's tongue swab or sputum. This should be clearly collected and reported. And then the outcome of the test conducted, so positive, negative, or invalid in very few cases. The test positivity rate is also very critical. And it's important for understanding of all the positive tests, of all the tests conducted, how many are positive. It gives some kind of insight to what's, sorry, I'm hearing an echo. Apologies for that. It gives insight into what the positivity rate is in that particular facility. And of course, it can be cascaded upwards to the higher administrative levels, so province, region, national level. The number and percentage of people with a new episode of TB who are tested with an NPOC at the time of diagnosis. This is a standard, this is linked, this should feed into the standard indicator. We all have the indicator on WRD coverage among new episodes of TB in the country. So this indicator should easily just feed into that indicator. And another indicator, standard indicator, which will also be linked to this is the bacteriological confirmation among pulmonary TB cases. But in this case, we expect to see that of all the new cases notified, how many of them had an initial diagnosis with an NPOC. And ultimately, this should also help improve the coverage of the WRD in a particular country. And then we should not forget the HIV indicators. And of course, the test doesn't test for HIV, but the status of HIV for the people who are diagnosed using an NPOC is definitely critical. And whether it's positive, negative, or no status, or just the documentation of the HIV status for that particular presumptive case, the particular case at the facility. Next slide. And then because the NPOCs do not give insight into the drug resistance pattern, it is also imperative that when the results of the drug resistance or DST, drug sensitivity testing, is available for a particular patient, that information is also registered at that facility. The WHO guidance clearly states that where a patient is notified, even if the specimen or sample is referred to another site for DST testing, the result also has to be recorded in that index facility, and that's where the notification will come from. And so, and it also gives a good reason for ensuring interoperability between lab information systems and existing systems. And even where the systems are not robust enough, or maybe it's paper-based used at that facility, it's important for that result to also be sent back to the initial notifying facility. And the last one is optional. Again, we have to also think of the patient beyond the testing, right? So once the results are available, it's important that the patient is linked to care. In a lot of facilities, the TB medication may be provided at those facilities, which is excellent. So just ensuring, but in rare situations where the patient has to be referred to another facility to take a medication, it's important that there's some information that those people are also put on treatment. But this is very optional. And in all that we do, it's important that we try to integrate these indicators within the existing health information system in the country as much as possible. All existing indicators are registered. But we do recognize that in some cases that will not be possible. And so in exceptional cases where these does not exist, then the country should make provisions for this. It's easier and faster for the uptake of and reporting of these NPOC-related indicators to take place within the existing system, because that would help for long-term sustainability. And so if you can move to the last slide, sorry. Next. Yes. And so I'll wrap up by saying all what I have mentioned are linked to these programmatic indicators, must also be within the core pillars of good monitoring and evaluation, right? So supportive supervision and oversight will be imperative when the early adoption takes place and the scale up. Data use and analysis for decision making and learning. It's important to also add the learning component, because a lot of the future scale up will build on what has been learned in the implementation next year. So that has to also be a key consideration. Accountability and communication, and this has to happen across all levels. Full ownership from the site level, health facility level, up to the national program and above will be imperative, and strong communication so that insights, if there are challenges, they are remedied as soon as possible, and so on. And then lastly, data quality assurance mechanisms have to be in place so that whatever information or data comes out or is reported by the system is viewed as reliable and operational. And ultimately, it will help the national program gain the best from this scale-up process. Thank you very much.
Thank you so much, Namdi, for the presentation. I'm going to invite question either from those online or those who are in the room. Please, if you do want to ask a question, please raise up your hand. Also, those joining us online, if you have a question, please raise up your hand. Dr. Maglit, please go ahead.
Yeah, thank you. Margaret Messinga-Luembe. I'm the chair of the Stop TB Partnership Global Laboratory Initiative. Thanks for the presentation, Namdi. I'm just wondering, so you rightly underscore the importance of the quality assurance mechanism, and also based on the contribution from the different countries here, I would refer maybe to Nigeria, but also the points that were made by Prof. Joloba earlier today. So we're taking the testing outside of the lab in most cases, or at the primary healthcare level, so where it's maybe was not there before. So I'm just wondering, why not also include an indicator around quality assurance as part of your programmatic indicators, essentials? Because we saw yesterday that it was quite important to monitor the early implementation, right? Just to make sure that testing is happening as it should. So I would like to have your comment on that. Thank you.
I don't know if any other person has a comment. You want me to answer, moderator, do you want me to answer directly? Or I take other questions?
Did you get the question?
I did.
Oh, please go ahead.
Okay, thank you. And thank you for your question and comment. So quality assurance is key, right? But again, my presentation is focusing on programmatic indicators, right? The operational level indicators also exist. And there are several indicators that would fall under that's outside the scope of this presentation. Quality assurance mechanism starts with the mindset, okay? Ensuring that the systems in place allow for only the right or correct data to be entered and reporting, and also that people are able to correctly capture the data and transmit the data. Here we are only focusing on the key program level indicators that would give you programmatic insight into what's happening. Now, I did try to put in the other slide that data quality assurance mechanism should be in place. And that's for the mindset. I don't want to preempt what will be presented in the subsequent presentation after this, where the operational level indicators would be discussed. But hopefully things like turnaround time, things like timeliness of reporting, completeness of reporting, and stock out rates and things like that are captured under that operational level indicator. I hope that clarifies a bit. Thanks.
There's one more question for you. Yes.
If there is another, I can.
Yes. Please go ahead.
Thank you. Just one aspect I think we need to consider in these indicators, I think would really be important for programs is error rates and indeterminate rates, because it's not considered, but this creates real biases in how you actually what your data looks like. Because I know we're talking from experience as South Africa, these have impact on programmatic indicators. So I think it might be useful because it also means an additional cost, a repeat test, and sometimes you lose a patient with an indeterminate result. Thank you.
Thank you for that. I believe that was a comment, and unless there's something you'd want to say about that, Mnandi, anything you want to say about that, as we all come off to ask a question.
Yeah, so you are spot on. It's especially with the gene experts, and implementation, we can see that. You will notice that in my slide, I did put the outcome of the test, positive, negative, and invalid and error, right? I understand that the NPOC device itself, the PlusLife device, the light you only see positive, negative, and I believe is the on sign. But information on invalid and error results can be gotten from the back end of this, and this would definitely impact on the number of tests that are used vis-a-vis the number of people who will receive a diagnosis. And this has to be considered throughout implementation. Thank you.
Thank you. I think I'm wondering why you left that question of linkage to treatment optional, particularly, especially when this instrument is going in places where we are not familiar with. I think we really need to stick on it, at least for risk resistance, even if you leave it for the other. I would beg. Thank you.
Thank you so much, Prof. Do you want to say anything about that comment on the need to have the linkage indicator not being optional?
Yeah, of course. The truth is, it is very important, right? The only reason why I put it there as optional is I recognize that in some settings, it may not be easy to capture it from that lowest level. But we are in this workshop and we are going to discuss further on the M&E plans for countries. I would strongly encourage countries to take that indicator up. Only where we have challenges, and I understand that we will have a panel discussion later today, we can all brainstorm and determine, are there ways that we can help countries that have challenges reporting that indicator so that all countries are able to put it in their system. Thank you.
So thank you so much for that. In the interest of time, I'll request that we move on. And Mnanji, in case you have any final comment.
No, thank you very much. I'll be online for the rest of the M&E session, and so happy to share my comments as they come up. Thank you.
Thank you so much. Ladies and gentlemen, I would want us to transition and get to hear from the country, and I'm going to invite Nyombi to make a presentation from Uganda. Thank you. Nyombi, please.
Thank you very much. Good morning once again. Abdul from Uganda, and before I start, I need to announce that our TB program manager is in the house, and maybe I will give him opportunity to introduce himself first.
Thank you, Abdunur and Chair. My name is Dr. Henry Luze, the Program Manager for Uganda TB NPOC Division. Came in this morning. I couldn't make it for the first day, but I'm happy to be here and listening to the presentations. Over to you.
So we are going to share about our experience in integrating new TB diagnostic tools into the existing M&E systems, but also following the presentation of where we looked at the outcome indicators, we are going to also look at some of the NPOC operation indicators that we should be looking at monitoring
Yes, okay, it's on.
Okay. Some of the operation indicators that we need to look at to monitor to see that we have an efficient and effective implementation of NPOCs in our country. And this will be aligned to what we need to do as Uganda, but I believe other countries could see what to pick and can fit in their setting. Okay, next slide. Can I confirm here? Okay. Okay, thank you. Thank you. So we all agree that appropriate monitoring and evaluation process for NPOCs should be put in place to support us to make a number of decisions. A number of countries are looking at starting with a few facilities and then seeing how they can be able to, based on what they see, to scale up to a number of facilities. But also we can see that currently all of us here, we don't have all of us here, if we go back and look at in our recording and voting tools, we don't have specific areas where we are able to easily capture data on NPOCs. And for us to move forward, we need to see that we have mechanisms to leverage on the existing data systems to be able to record and report in NPOC data. As for Uganda, there are three main systems that we use to report on TB diagnostic data. And mainly we rely on the DHIS2, which gives us aggregate data on a weekly, monthly, and quarterly basis. And also we have other systems like the electronic case-based surveillance system, which we're able to look at patient level data, and we're able to know the different diagnostic methods we've used to diagnose any TB patient that's being enrolled into treatment, and be able to monitor all the treatment outcome follow-up tests until we give different treatment outcomes. Then we have the third systems, which is the LabCoP, and this is a web-based data connectivity, similar to what other countries are using, like data to care and others. And this one gives us a chance to be able to monitor real-time the equipment, utilization, functionality, but also be able to transmit results to clinicians and patients to support eye linkage, especially for TB, but also most importantly, DRTB. Next. Thank you. So for us to be able to to say that we are integrating in diagnostics into these existing systems, it always takes time, and it also always depends on the timing that you have, where these tools come into the country. So if you are in a scenario where you have a tool coming in the country when the ministry is in the process of integrating, when the country is in the process of revising these tools, then you have an opportunity. But if you come in to introduce a diagnostic tool when the country has just rolled out the new HMIS tools, then it means that you wait for another cycle, which can take on average 5 years. So these processes are always lengthy and involve a number of stakeholders meetings. And then we'd have to do data mapping to identify the different data elements, the data sources that where we're going to pick these data elements. Because you realize that for the reporting, it is important to understand the particular data element you're going to use for a particular indicator to avoid duplicates. For example, if you're going to pick data for a number of patients that have accessed DST, 20 NPOC, for example, the best tool in our setting would be going to the TB treatment register. Because if you go into the TB lab register, in most cases, you have the same patient recorded, his results recorded at the NPOC testing facility, and the same result is in the lab register for the facility where they did gene expert or TrueNAT. So in that case, if you pick data for that particular patient, then you have two double reporting for the same patient. Then you have to go into the TB unit register where the patient has been on treatment to pick such data. So mapping the data sources is very important, but also the recording tools you're going to use for that particular test. Are you going to have this data in the OPD register, presumptive, lab register, and treatment register, or they're going to use specific registers? And also for the reports, are you going to use the weekly report, monthly reports, or quarterly reports? So this mapping has to be done. And then we involve the division of health information that does the programming of tools and the DHIS2 systems. We have to train users and then be able to monitor implementation of these tools. So that is the process we go to if we're doing accommodate NPOC into DHIS2 or the electronic case-based OSS system. And this can take some time, as I've said, depending on the timing of the ministry in terms of revising the tools. When it comes to the lab expert, which is the connectivity solution, in Uganda, as the professor mentioned yesterday, we've tried to look at the device from our collaborating laboratories, and our IT team have demonstrated that we are able to pick data from the Avero NPOC plus Life and have it onto lab expert. However, what is important is that you need to have a device like a phone or a computer, a laptop that can interface between the mini-doc and the lab expert interface. And that is currently not available on the provision from the NPOC, but we believe that probably in the near future, as we are looking at improving data connectivity, there could be discussions where we can have probably cheaper phones that can be provided with the mini-doc to support this aspect, or probably modifying the Avero mini-doc and they add a screen which can be able to have internet and interface with other doctor connected solutions, so that data can be transmitted seamlessly, but also be able to transmit results to patients, clinicians, and address issues to do with TAT. Okay, so in instances where we've been in similar scenarios in the past, where we have, for example, gene expert coming in, TrueNAT coming in, and then you are struggling on how to manage having data from facilities, what have we been doing as Uganda? So I'm sharing just a few examples. Around 2012, 2013, early years of gene expert implementation, all the tools in the country were fully focusing on sputum microscopy. And there were issues to do with linkage of patients, especially drug-resistant TB patients. So we had to kind of come up with an Excel-based tool, which had a few minimum parameters, because you create very many indicators, then you make reporting difficult to the people that are collecting data. So we came up with just a few parameters, especially looking at the cascade from sample receipt to results. And then we're able to come up with an email where all facilitators are having GeneXpert, we are required to submit this report by Thursday. And then our data officer summarizes these reports and shares it out with all the stakeholders, including the facilities, districts, partners, and then the DRTB treatment sites are able to look at this summary report and see that all the patients that are within this are being linked to treatment. And after this, we are able now to inform the ministry to be able to revise the tool in our weekly report and then accommodate GeneXpert into our weekly reports. So from the Excel-based system, we're able now to have the weekly surveillance report, accommodate GeneXpert, and be able to report on this and pick this data easily into DHIS2. Then the other example was on the TrueNat implementation, where we now had the report focusing on GeneXpert into the system, and therefore data could come from the laboratory register through DHIS2 and analyzed from the weekly surveillance report for the GeneXpert indicators. But now the issue was, how do we have TrueNat data come in to be reported and then analyzed? So the quick solution to this was now to train all the 41 TrueNat facilities to use the available lab register to record data for TrueNat as GeneXpert data, because the parameters are almost the same with the except of trace results, and then use the available reporting system for the weekly report to report the data into DHIS2. Then within the DHIS2, we requested the Division of Health Information to create a group within the DHIS2 interface, which they call TrueNat sites. So as every week, the data officer, the program can go into the DHIS2, pick data for all these parameters, and then for the organization unit, they're able to click on TrueNat sites and then pull out data only that talks about TrueNat and not another diagnostics like GeneXpert. And up to now, we are able to now to look at, analyze, and share data on TrueNat with this kind of system without changing the tools, but just training the users on how they can use the available tools to have this data come in. The other example is on the early introduction of the simple one-step stool testing, that is TB testing for children using stool. So in that case, we were able to, because we know that what was important here was to just identify the age of the patient and the sample type. So in this case, we are able to use the remarks section in the lab register to record the sample type, and then this informed the revision of the available lab register to be able to accommodate sample type as a column within the new register. And therefore, this data is now picked from just improvising the remarks to now making advocacy to the IT team at the ministry to accommodate sample type and able to pick that on SOS. So now, how do we plan to collect data as Uganda moving forward for this NPOC? So we realized that the number of processes in the laboratory, and the former presenter has been looking at the outcome part of this implementation. So our area is basically looking at the operational or the output indicators. And we've tried to summarize what would be a wish list for any program or entire country, starting from sample collection, number of samples tested, rejected, positive results, negative results, errors. You're looking at testing sites that are active in the country, the samples tested, demographics, HIV status for the samples being tested, looking at number of samples that are referred for DST. Then those that have positive results, because referring is different from having the results. You need to see that you get results back. Then we need to see that out of that are referred, how many are resistant patients, so that you're able to informed linkage. You can look at each enrollment. You can look at those are passing each way for quality assurance. We need to monitor the battery lifespan because it's important to know whether these batteries are going to take the 8 or 9 hours that we are looking at here, or in some settings could be low. We could look at monitoring stockouts, look at connectivity, facility data connected and those reporting. We can look at facility utilization rates. We can look at result TAT, and also look at yield versus of NPOC versus low complex NATs. So these are some of the parameters that we could look at, but the list can go on and on basing on the country settings. So what are we looking at as for the start of the implementation? So looking at 2026 and after reviewing the available tools and M&D system, we think that we can comfortably report on only 8 parameters. And our focus will be mainly on the samples tested, rejected, positives, where we shall monitor positive rates. We need to look at samples that are having DST results, and then those that are resistant for informed linkage. We're going to look at error rate and number of mini docs working at a facility, and then the test cards remaining. And this will be monitored at a weekly basis. And we expect to be able to use, sorry, it takes longer a bit sorry, yeah. So we expect to use the available, sorry a bit. Yes, so we expect to use the available lab register, which I've already showed us. And this register, oh, what's happening? Please help me. So we expect, very good, thank you. So we expect to use the available lab register. And in this register, we are looking at the column of others, where we're saying others specified. That's where we expect to put the NPOC results, and then the report as positive, invalid, or negative. And then for that particular patient, we expect a sample to go to GeneXpert or TrueNAT, and we expect to put the results for NPOC in the column of NAT. And in that particular case, we believe that for every result, every patient had a result for in other specified must have a result in the column of NAT. And for our setting, we would want to wish that we maximize collecting sputum, so that every patient can easily access a DST test. It's only those few that will focus on So in terms of the reporting, we are going to use the available weekly report. Like I said, this data will be collected on a weekly basis. So we are going to use the available weekly report. And within that weekly report, there are 2 sections that will be of focus. Table 9 will focus on the lab parameters from sample testing to monitoring functionality of the equipment and stock status. And then we shall look at table 6, which we shall look at, see the bacterial confirmed TB case tested with GeneXpert. And this is a section we shall look at those that are positive on NPOs and having a GeneXpert or the TrueNAT test. And then the DHIS2 interface, we shall add a group of TB NPOC sites. And therefore, our data team can go every week within the system and pull out data for the NPOC sites, focusing on those 8 parameters that we are going to focus on for 2026. That's one, I think. Okay. So other options that we have the TB info. So the TB info works with also the DHIS2 interface, but for it, it can be used when you have want to collect a lot of data at the same time through the data calls. So the other very many 20-something indicators, in the case we want to have either on a quarterly basis or on a monthly basis to pick more data for what we are, how this test is performing, we can use the TB info, but also we can look at exploring ECBSS for reporting. Thank you very much.
Thank you so much, Nyombi, for that. In the interest of time, I'm going to say hold on your questions so that we can have the presentation from Nuru, who is joining us online, and then we are going to have the questions after that. Thank you. Nulu, if you can hear me, please.
Yeah, I can hear you. Yeah, good afternoon. My name Nurul. Yeah, my name Nurul from Indonesia. I will presentation about the monitoring NPOC and then about the intermediate result interim, yeah, about the pre-pilot NPOC in Indonesia. Yeah, what we Pak Andri preparation yesterday, we are currently conducting a pre-pilot for utilization of NPOC from August until December 2025 as one-stop service OSS project integrating with the X-ray, NPOC, and Gen Expert with the following implementer from the Mitra, Evident, Pajajaran University, and the World Bank. And the number of puskesmas from the site evident is 3 puskesmas, and each puskesmas in evident have 3 mini doc and 1 thermolyze. And rather than in World Bank, have sorry, a number of puskesmas is 5. And each puskesmas have 5 mini doc and 2 thermolyze. And the objective or evident for pre-pilot first one is assess feasibility and acceptability of NPOC use in health facility and the cost effectiveness analysis. And the objective for the pre-pilot from the World Bank is compare the yield of NPOC plus case and of TB case, including clinical case, using 2 algorithm. NPOC as screening tool and NPOC as diagnostic tool. And then the objective about the cost effective with the 2 algorithm. And about the algorithm in evident or NPOC as diagnostic tools for people with symptom, and then the World Bank NPOC have 2 using, yeah, NPOC as screening tools for all people with or without symptom, and then NPOC as diagnosis tool for people with abnormality from X-ray screening and or with the symptom. And the indicator in the evident, yeah, number of the TB suspect or presumptive undergoing NPOC testing, and number of TB suspect undergoing NPOC testing with the positive result. And indicator in the World Bank is number of people undergoing NPOC testing and number of people undergoing NPOC testing with the positive result. About the interim result, yeah, because the pre-pilot is not a final, yeah. From the World Bank pre-pilot, we have a total participant until 11 October. We have around 3,000 participant, and each participant they examination with the X-ray and NPOCT. And the result in the table about the NPOCT result, yeah, with the algorithm number 2 as what we mentioned, NPOC as screening tool, it's much more expensive to implement it because it's required 10 until 15-fold higher number of NPOCT tests. About the cost effective is analysis to follow. And in the result, especially type of sputum sample, with the World Bank, the table result, especially presentation is mycopurulent is much higher to NPOCT positive, and the pre-pilot we capture about the use tongue swab, and about the result is just not much higher with the tongue swab. It may be from the pre-pilot with the WB more cost effective use sputum sample only. But in the evident pre-pilot is different, because in the evident pilot result relevant in NPOC, the number of participants until 10 October is around 1,000, and each participant have testing with the sputum swab and tongue swab, and the result about the positive rate NPOC using sputum swab is higher rather than tongue swab. But the result is we can see the NPOC with tongue swab we can adapt more with the program. And then the next step, the MONEF NPOC TB to expand more, we planning conduct evaluation of the pre-pilot result from 6 health facility, from the evidence and from the World Bank, to determine a logarithm, policy direction, and developing related technical guideline, because the two pre-pilot is a different objective, and we have more evidence about use NPOC is screening tools or diagnostic tool, or the algorithm is more effective with the NPOC, especially follow up result from the NPOC. For example, we need confirmation testing from gene expert or not, and I think we need make sure about the algorithm. We planning update the national TB diagnostic algorithm to include NPOC. Currently we process and make sure about the monitoring and evaluation. And we just discussion about the algorithm with the pilot in 2026 in 200 puskesmas in January until March. And indicator what we monitoring especially in 200 puskesmas for example number of suspect testing in NPOC, number of positive NPOC result, number of negative NPOC result, type of sample test, and about the of positive NPOC test with the DST result, and other indicator. I think we need more discussion again about the indicator we use in piloting in 200 puskesmas. Maybe finish from the Indonesia side. Thank you.
Thank you so much, Nulu. Thank you so much, Nuru, for that. In the interest of time, I'm going to request you to stay online. I would want us to go and grab a cup of coffee for about 15 minutes. And then when we get back, my brother Oba to take it up from there to we transition from the questions to the plenary. So please, let's grab a cup of coffee and be back here in 15 minutes. Thank you so very much.
You start? Okay. So since we have Abdunu and Nuru available for questions, are there any questions for them? Any questions from the two last presentations?
Okay, thank you. There are nice presentations from both countries. Good experience. Just have one question on the lab register for Ugandan team. They are using the same lab registers, I think. I'm not sure if they have a hard copy of the registers. Otherwise, printing is very, very, very expensive. So as they got just one test, they revise the registers, or I don't know how to do that, because in our case, it is very difficult to print the registers. It's very expensive. So are they going to use the hard copy or just only the soft copy? Just clarification. Thank you.
Thank you. Maybe we have another question, then we will take all of them.
Thank you. My question is to the second presenter. Thank you for the nice presentation. I wanted to ask the population in which you are running these tests, because I saw that in one of them, the positivity rate is even up to 17%. So are they key populations or are they general populations in Indonesia? Thank you.
Any other questions? Yes.
Thank you. Maybe my question is related to the indicator part in general. So the question might be simple, but it will be asked at the health facility level. So can we continue with the name of NPOC? Because there are many near point of care at health facility level. For example, if we take microscopy by itself is near point of care, urine lamp is near point of care. So can we continue with NPO still at the health facility level? This question will be moved at lower level when we back to our country. Thank you.
I hope somebody got that question. Did we get the last question? Okay, you are going to answer? Okay, thank you. Last question before we ask the presenters to respond.
Okay, thank you for the opportunity and the presenters that give us an overview of what they've done in Uganda. So my question is to the NTRL Uganda. The first is, in this presentation, you showed MPMA as part of the platforms that was linked to the Lab Expert DS. So I want to know if MPMA tests for TB, or are we trying to do TB HIV, just for clarification for that one. Then I think I should first mention that seeing that Lab Expert DS, it's speaking to the needs of my country, Nigeria, and it's something that, yes, we can learn from. So I will ask two main questions from there. Does the lab experts provide SMS services to both the program and maybe the DRTB focal person, especially to alert on reef resistance status for that platform? Then next is, do they have an existing LIMS, or is the lab expert DS a standalone laboratory information management systems? Thank you.
I think we will try to answer those questions. Abdul, let me start with Nuru first online, then I come to you because you have more questions. Nuru, do you want to answer the question about which populations you are targeting?
Yeah. Yeah. About the eligible participant in the pre-pilot, especially in evidence setting, the eligible participant is people have presumptive TB ya. People have a symptom TB with follow up with the NPOC testing with the evidence site ya. And the WB test, WB site, the NPOC use with the screening tools and diagnosis tool. Especially in WB setting, NPOC, the participant is eligible all people coming in facility with the symptom or not symptom. And the result is different. In setting evidence with the people with the symptom, positive rate is much higher, but in the WB setting, the eligible participant is all people coming with the health facility is lower.
Okay. So it's just general population, I think. That's what she means. Eh? Okay, good. And for
Yeah, thank you very much for the questions. So I will start with the one of the lab register, whether we are printing hard copies or it is electronic. We are having a vision as Ministry of Health Uganda to go paperless, to have electronic system for recording in the lab and other service delivery points, but also be able to report data to the ministry. But this is being done in two-phased approach, and currently we are at the high-level hospitals. So targeting that these devices are going to be at lower-level facilities where we know that issues to do with connectivity and all that are not that efficient. We are going to start by having the hard copies of the registers as we scale up the electronic systems. Then on the issue of recording NPOC and having different NPOCs in the facilities, I think this will go back to the true definition of what we are calling NPOC for TB. And we all know that we are looking at portable devices that have simpler maybe service and operational requirements. So issues like LF-LAM, those are point of care. Issues like microscopy may not be qualifying as NPOC. So I think as we go back to our programs, we need to clearly define to the users what we shall be defining as NPOC and how to document them. Then for the issue of the lab expert, currently in Uganda, the lab expert is able to accommodate more tools beyond the TB program. So we are having the MPIMA for the HIV, we are having the CD-active protein like Afinion products, Dict X-ray, and we think that it can take up other tools. And that it has the capacity to transmit SMSs, not only to the patients and clinicians, but also to the DRTB treatment centers and the programs. But it just goes to how much you need to accommodate and program it to do. In integration, we've done integration with DHIS2 and the electronic case-based surveillance system. So this is what we've done, and we are looking at able to scale up to other systems that are available with the different tools that come in the country. Over.
Is there another question there?
Yeah. Okay, thank you so much for the opportunity. I just wanted to check something because in the list of indicators that you were showing, there was one that talked to sputum rejection. Is the device or the platform able to generate a rejected sputum? Because I saw 3 results that can actually be generated, negative, positive, and invalid. So how do you then gather information on sputum rejection?
Thank you very much. So the first list has a wish list of 20 plus parameters. And in some settings, people think that the quality of sputum could have an impact on the result. And so it will be important probably to see at the lower level facilities to try to look at the quality of the sputum that's coming in the laboratory. But this will not be a parameter that you can pick directly from the device. However, we believe that labs should be having kind of registers that could be able to document the sample that they are receiving in the laboratory and then look at the quality of the results. And if there's any rejection, then give reasons why they're rejecting a particular sample and then track the rejection rates. So that is the speed we're coming in, but it should not be, it is not like an indicator we expect to be looking at on a weekly basis. It's not among the top priority indicators look at the weekly basis. It is pre-analytical, yes. It's pre-analytical. It's not part of the analytical. It's pre-analytical. Pre-analytical before the people. Yes. The person rejecting, not the instrument. Yes.
Okay.
Yes.
Okay, thanks.
Okay. Okay, thank you very much to the Indonesia and Uganda teams. Maybe we can give them a round of applause. Unfortunately, we are behind time. Thank you so much. So we've had, I think, some kind of like tester in terms of what systems we can start thinking about to get data, isn't it? And we have like 4 questions we would like to ask, and we also have 5 minutes to answer those questions. Yes. So I think we would like to hear from different countries. We've had the Uganda situation, and we've heard from Indonesia. I would like to hear from you what you think in terms of what routine systems or what routine data systems in your country could have like the greatest potential for integrating NPOC matrix that you are going to collect, and some that have been shared, and what adaptations are necessary to make them work in 2026. I liked one of the examples that he used about just putting other in the remarks column, and some just, trying to retrofit in existing lab registers before we start committing funds. As he said, registers are expensive. But just to hear from the different countries what your thoughts are on this. Any takers? Yes, from Kenya. Thank you.
Thank you. So I think for Kenya, let's be realistic. I don't think I've seen you looking at your watch. You have already taken the 3 minutes. So one is that we don't have digital tools tomorrow. So we already have testing going on using those existing registers. Those exactly like the columns that my colleague from Uganda has mentioned do exist. Some of them have some columns remarks. So during capacity building, then the end users can be trained to where to capture this data. But in the initial few sites, yes, an Excel can do, where some folders are made for these new facilities to be able to capture this information. But I think to the existing digital solutions, like Nyombi has mentioned, there are the IT guys working with the laboratory colleagues to start updating those systems. That works. We did do initially USAID project here in Kenya, and one of the things we did was to look at the existing reporting tools, and we did organize to have introduction of TrueNAT into the system for reporting purposes. So that can happen with the existing reporting tools. But also more importantly is about the issues around commodities. So for us, we used to have HIV, TB, malaria, commodity reporting tools in all the facilities. But now we have collapsed all that into one. So it's already uploaded to KHIS, where we have an MOH integrated commodity management tool, where all the facilities, when they open it, then they can put data there. So I think one of the gaps that we foresee there is that the testing facilities may not be able to upload this data directly from the testing sites. But at the district level, where we have some hardware, then it is easier for data to be collected from the testing sites And then the district level, for us, is a sub-count. This information can be uploaded for national use to make decisions. I think that's for question 1. Thanks.
Thank you very much. Any other takers? Someone else want to say something? Let me pick some countries then to put some people on the spot. I think that will make life interesting. Maybe let me hear from colleagues in, I'll start with Zambia because they are close to my country. People from Zambia, what are your thoughts in terms of where you can get data from and how?
Good morning. How are you? Yeah, it's interesting. I think that we would like, to see, especially on the existing data. I think our discussion so far has been how do we integrate the existing platforms where we're collecting the data. And I think that's been the main discussion around how do we integrate this into our DHIS2 as well. I think that's a potential thing that we're looking at mostly, because I think that helps us to collect that particular data. But also how we improve that quality of data and completeness. I think for a long time that remains a challenge with the other platforms that we're already running. And we see that probably that will remain a big issue for us as well in terms of just how do we have the completeness, timeliness of the data as well remains a big issue. Yeah, thanks.
Yeah, and any plans to address those data quality issues?
So the plans, like I can say, are iterative. I think that we've tried to step up doing, review of data periodically, that just to keep the people on the grounds. I think a lot of integration of the leadership at district and provincial level has been one of the steps we're trying to see, so that as the transmission of the data from the primary side comes to the program, there is a lot of leadership looking into that program data and maybe seeing the completeness before it gets to us. We will see how DQS can help us. I think they've been helping us in the past, and maybe there would be a step that we could still integrate in this process. Thanks.
Okay, I'll also ask from the South African colleagues, because you started some information systems with GeneX, which I think you were one of the first countries to implement. What are your thoughts on NPOCs now?
So we just had a quick discussion about this, right? So there's 2 components to it. The first component is the lab component, through which we do lab surveillance. There we would require the NPOC to interface into our lab information systems. That's if we're placing these platforms within the lab environment. Once it's there, we then easily connect to the system. It interfaces with our lab information system. We collect the data in a central data warehouse. We're able to report, because currently we're doing it with our diversified TB NAT, where we can disaggregate by the platform that the test is performed on. So this would then just be us creating that parameter for NPOC, and we disaggregate further. That is the first component. The second component is this will limit us to lab infrastructure. If we were to decentralize or move away from the labs, then we would need to find a new solution. But I'm aware that this system is able to transmit data into a cloud environment, and potentially we could then interface the cloud environment with our lab infrastructure. So that would be potential. But then in terms of reporting on the register system, so in the fields, essentially we're having this discussion, it's a TB NAT. So ideally it should be registered under TB NAT. But then again, we're going to do a repeat test for those that are positive. And where do we capture that information? So that's as far as we got with our 2-minute discussion. Thanks.
Okay, very good. Any other thoughts about this? Has any other country had some thinking? Maybe in Nigeria, I know that you are thinking about lab expect yes, but so before maybe with that, what do you think?
Okay, for Nigeria, we have an existing system of picking data from the community and also which leverage the platforms for testing. So we use, what we just thought about is we could use the Kobo Collect, expand the module to include NPOC reporting. The Kobo Collect is a real-time reporting tool that we even use it, it's interfaces with the mobile device. So it's not necessarily have to be a lab-based computer system. So we can use that because our setting is to look beyond the laboratory environment to deploy the NPOC. So that we use Kobo Collect at the interim while we're waiting to have our robust laboratory information management systems, then that can capture the data real time.
Any other country? Any thoughts? Colleagues from Peru?
In Peru, we have a system which is responsible for national laboratories. Now, all the cases which have been submitted to diagnosis test, the only adaptation that we need to do is to put the number of the test on the platform, because for us to collect all the data, we are collecting data of expert, TRINAT, and we need to aggregate the types of tests. And also, as national program, we have a nominal system in which we register all the cases that are screened. Now, we use the system of laboratories automatically with GNI so that we can collect data which have been put in a laboratory system, national laboratory system.
Thanks. Any other country? Okay, last comment from Ethiopia, then we have to close. Thank you.
Okay, thank you. Most of our system is covering almost all health facilities is for MND part, that's DHIS2. So we are focusing on DHIS2. But the challenge is we have to be very selective for indicators. Okay, so for selective indicators, we will plan to integrate with the DHIS2. But I have one question for countries who are going to select lab expert connectivity. Lab expert is working only for the sites that GeneXpert is available. So are you going to give this machine again for GeneXpert sites? Otherwise, how can we go integrate it to lab expert connectivity? Maybe Uganda team.
Yes, there is.
Yeah.
Thank you, my brother from Ethiopia. So well, like I've said, in the current state of the equipment, it is quite tough. However, what you need is to have a device like a phone that can be able to have internet. And then once you program the lab expert software, then the software will communicate to the MDoc device through the phone. Then you're able to transmit that data. So that is something that is missing, but I believe it is doable because there could be cheaper phones on the market that we could get and work with to have that. And another thing someone could think, if a lab technician has his own phone, could we use it to do that, to serve that purpose? Then maybe issues like data security and confidentiality could come in, but there are a number of things that we could explore in that lane. Thank you.
Thank you, Bashir. Thank you very much. Thanks everyone for the session. I think it's been very interesting. Now I hand you back to Melanie.
Thank you, Obat and Michael, for moderating the M&E session. I think it's been very, very useful. And also thank you to Nurul and Abdunor and Namdi, who all presented. So we want to get into the breakout room discussions now. And I think the intent for what we're trying to do before lunch is to see, having had all that you've had yesterday and today, is there any refinement that we need to make to the implementation plans, understanding that the scope of the early implementer initiative is really 2026 to maximize impact? So I think what we want to do before lunch is look back at the country plans, see how we're incorporating monitoring and evaluation into those country plans, and then articulating clearly what the TA or implementation support needs will be. And then we will break off for lunch. And then when we come back, we'll still stay in our breakout rooms. But those discussions will then be focused more on the procurement process in terms of the timelines, the quantifications, and order placements. So that's how the program has been designed. We've separated the room, the countries into 3 separate rooms. So for Bangladesh, Ethiopia, South Africa, and Nigeria, you just have to walk to the next door, and there'll be each country will be placed on a separate table where you can have those discussions. We also have some technical partners who are present in the room and will be a part of each of the country discussions, and a few of them will also be roaming around to help address any of those questions. So for Bangladesh, Ethiopia, South Africa, Nigeria, you'll be in the room next door. Benin, Peru, Cameroon, Vietnam, Zambia, Uganda, Kenya, we're all staying here. Indonesia as well. And for Philippines Online, we're going to create a breakout room for you in a few minutes. And so we'll also have a partner join that breakout room for those discussions. For lunch today, we're not going down where we were yesterday. Lunch will be outside. So at the end of this corridor, walk straight and turn right. We plan to have lunch at 1 p.m. So we're going to have an hour discussion now, and then at 1 p.m. we'll go straight out to the right, and that's where lunch will be today. And then when we get back, we go back into the breakout discussions. So yeah, I'd like to ask the countries that are moving to the next rooms to head there: Bangladesh, Ethiopia, South Africa, and Nigeria. You'll be joined by some of the technical partners, and then the rest just congregate at a table within this room so that we can continue those discussions. Thank you so much. Are there any questions or clarifications? For the countries that need translation, so Cameroon, Benin, Peru, ideally everyone on the table should be able to speak French, but if you need translation, you will have to join in on your laptop and put the headsets on so that we can get real-time translation. Yeah. Hello. Can we get started? Could the people outside please come in? Mohammed. So we're going to have a wrap-up session. And I think now is an opportunity to ask any outstanding questions that have come out of the group discussions, areas that you need further clarity on. So we'll allow some time for a Q&A, and then we'll have some closing remarks from Eliud Wandwalo, the head of TB at the Global Fund. And before that, Muhammad Farag will give us the next steps for what is needed. So please get seated so we can start. Thank you. Okay, I think we have an almost full house. Thank you again for spending the past 2 days working so tirelessly to get this up off the ground and running. We really appreciate all the time, all the effort that has gone into planning for this. We also realize that the breakout discussions have generated a lot of discussion, a lot of questions that you probably need further clarity on as you finalize some of the planning. So we have a few minutes to go through any outstanding, any burning questions that you have from the breakout rooms. For those online, feel free to raise your hands if you're still there and you have questions. The Philippines team, Indonesia team. So I'll open it up. I don't know if our IT guys are available to help with passing the mic around, but do we have any questions? Are we all just too tired? No? Yeah, there's tea outside as well. But any questions? Oh yeah, Dr. Shayla, it's over here. Thank you.
So just to know that about the pricing, actually, we have seen that it's 5.04 plus $2 copay. So this will be considered for 2026, I think. But what is going to happen in 2027 and 8 subsequently, the price? So that's my question. Thank you.
Thank you. Good question. Amin and Garnia, you should just take seats on the stage. Mohammed could come. Patricia, if you don't mind coming to the stage as well, just so we can have you close by to answer some of these questions.
So while we're waiting for additional questions, let me answer the first question. The pricing officially is $3.70 per test. $3.60 per test. That is the price that is going to be listed at on Wambo. So that is the price that you should use for your quantification. For the thermolysis machine, it is $180. And for the mini doc, it is $150. So that's what you should use for your quantification if you want more. These come with a 2-year warranty. If you choose to extend that warranty, it is $60 per machine for an additional 2 years of warranty to make it, instead of 2 years, make it 4 years. So when you are quantifying for 2027 and 2028, those are the numbers that I would say to use for now. Sorry? Oh, I should repeat it again. Sorry, you can't hear me. Sorry, my voice is going. Don't be angry. I'm trying. Okay, so one more time. The price is $3.60 on Wambo is what you would pay per test. I mentioned earlier that the pricing for the tests, we have negotiated, or Gates has been so kind to negotiate a price that goes down to $2.50 by mid-2027 or after the procurement of 7 million tests, whichever one comes first. So by July 2027, your $360 turns to $250. That's tests. For equipment, you are budgeting $180 for the thermolysis machine and $150 for the mini doc. For that amount, it comes with a 2-year warranty inside that amount. If you choose to extend that warranty by an additional 2 years, it is $60 for every machine that you want to extend the warranty for. Noting as well that the warranty is a replacement and not a, it's not a repair. So they will take your mini doc, take your thermolysis, and give you another thermodoc. I said thermodoc. I've added everything together. Thermolysis or mini doc. Yes. I hope that answers the question. More question.
We have one more question. And then Jeremiah, and you as well?
Okay, we want to clarify regarding the decentralized use. Okay, we want to negotiate for the decentralized. Yes, it's a negotiation, yes. Because from our scenario, we have that the possibility of having the 4 mini docs, 2 thermolyzer, and still be able to test 1,000 tests per year for the first year, for 2026, because we are just starting up. And so we also don't want to burden the facilities, and we know startup of new equipment such as this will need us to first get our own momentum together. Then in 2027, we have this instruments performing at the optimal capacity. So we can have the 2 mini docs and 1 thermolyzer test for the 1,000 tests per year. So these are negotiation. 4 mini docs at decentralized use, mobile use, with 2 thermolyzers, and still test 1,000 tests per year.
So the request is to reduce the tests to 1,000 tests. Okay.
For some.
For? No?
For the, the decentralized, if you use that demand template, the decentralized use says 1,000 tests, 2 mini docs, 1 thermolyzer per year.
And the battery.
And 1 battery.
Yeah.
But because of the need for battery, we have a need for battery, we have a need for thermolyzer and mini docs. So to also maximize the use, the funding available for 2026. So we want to negotiate that 2026 availability to 1,000 tests for the 4 mini docs and 2 thermolyzer.
That sounds like bundle 3 is what I was saying, with less tests.
With the battery.
With a battery and
With
less
the battery,
tests.
yes, lower test. Thank you.
My answer to your question is thank you very much for sharing. Very highly noted in what you want. I will need to go back to our direct sourcing colleagues to run the numbers, and then I will come back to you on what is feasible or not feasible. That is my diplomatic answer. Sorry? No, to run the numbers. To run the numbers, and then I will come back. But I think the purpose of this, right, is, and I said this when I presented earlier, is to know what works best for you. So we will take this as this is one option that Nigeria wants. If other people have similar, then, let us know, and then we know what makes the most sense for implementation. Are there any other of the option? 315 and 1.
Yes.
Okay.
Then the higher throughput also makes sense. But what they even did in our own scenario is to increase the capacity. It's supposed to give us 8 tests per day for the higher throughput for the 3rd bundle. So what we put here is to have 16 tests because it has 4 mini docs. So we can maximize that in our volume facility.
Okay, so the only one that you want to potentially tweak would be bundle 1 to then become...
So you have more thermolyzers.
To have more thermolyzers.
Mini docs.
So 1 additional mini doc.
Then 1.
2 additional thermolyzers and 1 additional battery. So basically doubling it, but putting the same number of tests is what you're saying.
Yes.
Doubling the equipment for the same number of tests.
For 2026.
Okay.
So 2027, it picks up the normal testing capacity.
Okay. Thank you very much. I have noted it, and we will take it and let you know what makes sense. There was a question from Peru. I saw her on.
I want to. I was thinking about the sustainability so that with the public funds, we can consider the cost of tests, which can be included. All the equipment can be included, because I'd like to say that we as a country, it's a bit difficult, the procurement of the equipment, but if you use that modality of buying input and including equipment, that will be easier so that we can expand the testing in our country. I don't know, I would like to know if we can consider that in future.
Just to clarify, sorry, oops, I would hear my voice. To clarify, your request is for bundles to also remain later for domestic funding. So after this procurement support, you're requesting that we keep bundles even after for domestic procurements using country's own funding. Yeah. Okay. Is the answer.
That is a type of bundle, but of course, it should be budgeted from by the government. It's like a bundle.
Okay. Yeah, I think that definitely is something that is possible to maintain the bundling within the procurement platforms. What I cannot 100% confirm now is on the domestic procurement side. I know that we have processes for domestic procurement through WAMBO. If you're willing to procure domestic procurement through WAMBO, then I think that is possible. If your question is outside of WAMBO, then that one is where I would need to check with direct sourcing and with our procurement management team on what makes sense. But if it is through WAMBO, wanting to have bundles with domestic procurements, then I think that should be feasible. Okay, answered. Is that Jeremiah?
There's a process.
Jeremiah, you had a question, right?
Yeah, on these cost per tests, the possible reduction in terms of reaching the 7 million tests, is it possible as countries, people can come together and do pooled procurement? We initially had discussions on how best if volumes can be put together, because I may not reach the volumes as an individual, but if we do pool procurement, then the volumes may be what is required. The second one is about WAMBO, PFSCM. From what we presented yesterday as a country, sitting back to look at it and looking at the time it takes to get the products here, and we know from production to delivery 13 months. So we may end up receiving these commodities when they are 6 months or thereabouts. So I know you don't work in WAMBO, but what Professor Joloba said yesterday, what we are fighting is what he called a thing, microscopy. And that's what we wanted to see how we can have this as a first test. So is there a possibility to engage WAMBO to see how these TATs and procurement processes can be very short, especially for this type of a product? Thanks.
For WAMBO is a procurement system within Global Fund. So we, I guess, do work with WAMBO. And but what I would say is that for this, we're trying to maximize your shelf life. The intention for the procurement is to make sure that we don't have too much of a delay, which is why for this initial procurement process, we're even offering air freights to get it to you as quickly as possible. What we would like to do, and I think I had come to quite a few groups and also discussed about staggering your deliveries of your tests, because the machines are fine. There's no shelf life issue with machines, but with the tests, we're asking that you stagger your tests so that we can maximize it. And you're getting at least, if we maintain 13 months, 11 or 10 months of the shelf life upon delivery. So if we are able to stagger our deliveries, then we should be able to do that. But we're also going to, on our end, try to fast track the procurement process through WAMBO, because we know that this is something that is very time sensitive. We don't want you to receive tests and they're all expired. There is also the I think from the purchase order points is where we would want them to give us newly manufactured tests so that it shortens the time that it takes to get to you. So once it is delivery, we want it to be a freshly manufactured test that has full lifespan that is being sent out.
Okay, so to your very good points mentioned. And again, I'm trying to emphasize that to everyone in the room that doing this introduction should be put in your processes in the country, the standard processes, but with the caveat that this is not business as usual. Again, why is that not business as usual? Because we're trying to do an accelerated access. We're trying to offer that accelerated access to you. Why it should be fast and with speed is because the products are subsidized from another source. We are leveraging basically the private sector contribution from CIF to subsidize that, right? You're paying only $2 for a $7 package, okay? So the implementation in the country have to follow that. Now, how much time do we have? It's 2026. Not for implementation fully, but at least for your deliveries, your first deliveries will have to be in the country, and you'll have to start your first rollouts in the site. Obviously, that can slip to Q1 in 2027. That's okay, as long as you have received your deliveries in 2026. Now, what does that mean in actuality for your processes? To the point that was mentioned, registration, procurement process, importation, and then we have the constraint on the shelf life, right? So you will get the product, as we mentioned, ready at 13 months at the supplier. Count 2 months to come in to the country with air freight. And then your processes in country, you have to cut it as short as you can. From our side, it's only one supplier. So we don't have allocation kind of situation where we have 4 or 5 suppliers and we are thinking how much we will allocate to each of the 4 or 5 suppliers from the volume that we got. It's only one supplier. They will get all the volumes depending on the demand plan that you have communicated to us and your delivery need by dates. So it shouldn't take much time on our side in terms of procurement process. Okay, what you need to think about really is these things: registration or registration waivers, importation and import authorization permit timelines, distribution timelines in the country according to the readiness of your sites, right? Because you want the products to come in and then the installation kicks in immediately without having to wait for the sites to be ready or for the staff to be available. So all of this needs to be communicated from the central level to the sites early on, right? And then you have to think about, okay, when I will get my product in the site ready to be receiving samples and running it. Is it 6 months? I think this is a very conservative estimate considering this. And if we follow that 6 months, we will start shelf life remaining. This is the first test we are getting. I think that we will be doing business as usual, right? But if you think that I'm going to be ambitious, I'm going to accelerate my processes, then probably you can get something about 10 or 9 months. So you will gain more shelf life. Now, this is assuming again that we haven't gotten yet the extension from the supplier. If we've gotten that, we'll all be happily surprised, but we shouldn't plan for it until it happens, right? If we get 18 months, then everyone will be happy. So I'm emphasizing this again, please. Let's think that these processes you will have to have your support, and we will work with you in whatever capacity you require to actually, and through the country teams, to actually get that support from your different entities that are involved, whether it's your FDA, whether it's your Ministry of Finance to get tax waivers, whether it's a different entity within the Ministry of Health that the TB program does not usually work with. So all of these things you have to start thinking about, okay? Now on the pool procurement, basically that's what's happening. We're pooling the volumes from all the countries, and we are going to the supplier, and we are negotiating based on these volumes. Why we're asking you for 27 and 28 demand? Because this will give the signal that was requested by the supplier to know, to have the visibility. Suppliers care very much about the future in order to plan their production for success. So in that case, you have to provide us these demand estimates as firmed up as you can for 26, and for 27 and 28, these are the volumes that we are going to work with the supplier to get into the final price that then you can leverage through your domestic financing or through WAMBO or through other platforms beyond 2026 and beyond this early access initiative. So I don't know if that answered your question, but I think that it gave everyone an idea that we have to go fast on this. Please.
I understand that you want to go fast, and I appreciate that. But there are some challenges. The main one is what is within the country. There are some actors, they are not here. You have the principal recipient, you have the local fund agent, you have the country team. These are people, since we have to involve the country grant, these are people very critical in this process. And doing the fact that we have some complexity, it depends on the country, but in some country, it's very challenging to implement an activity. People are fearing not eligible costs than fearing not implementing activities. And so what you put in place as a system so that these people, all these people are aligned on what you are looking for.
Yeah.
If not, at the end of the day, we will not be able to implement because of those complexities.
No, it's a very good point, and thank you for this. And let me emphasize that this effort is very much aligned with the country teams. Okay, so there are some country team representatives in the room, obviously. There are some country team representative online, and there is a communication that went out from our grant management division leadership that actually endorses that work. So rest assured that on this end, the country team will be engaging with you in a collaborative and facilitative way. Now, obviously, each country has its own intricacies and its own situation. In some countries, you might need to work out the details of the non-product costs. So all the trainings, all the workshops, the basically now will have to be online because of the cost considerations. And I understand that this is not always preferable, but we'll have to work with whatever we have within the grant, right? So that's something that we leave to the country teams to decide with the implementers on. But on the engagement, on this access initiative, and on the speed that we need to go with, I think the country team will be facilitative and supportive towards that with the country. There was something on this side? Yeah. Wayne, yeah.
So I just had a comment on the previous topic about procurement and pooled procurement. So of course, all of this procurement is happening with the Access Fund and through WAMBO, but at the same time, GDF, Stop TB's GDF is also negotiating with plus life to get products in the catalog. Pricing is going to be the same as what Amina was just describing a moment ago. And when it comes to this price drop, when set procurement, of course, countries who aren't in this room, they might be using global fund money to buy. There might be some other donors interested. Domestic funding can also go through GDF.
So thanks for this, Wayne, but just for clarity of everyone, for this particular initiative, it has to go through WAMBO. So that has to be clear. For future, of course, with more platforms, more access and procurement channels, the country will have the choice to make it. Yeah.
Jean Dudu, online, could you please ask your question?
Yes, thank you very much. Do you hear me?
Yes.
Yes, thank you very much. And I would like to really to echo on these 2 points, food procurement and the shelf life. Let me start by shelf life. Colleagues who are in the room, we all know that we experience the same problems with the gene experts. At the beginning, the shelf life was not longer, and then countries really were into a struggle. However, we learn from that time. I think we need to go back and apply lesson learned when we implemented experts. This is really something I would like to highlight, and I would like to invite everyone to think about challenges countries they experienced during that time. And then we can avoid those challenges, assuming that the shelf life will be longer as you move on with the implementation. That's really a point which is, for me, very important. And thank you, Wayne, who stated that GDF is planning to have this product also into the catalog. And in such case, other countries in our region can at least have enough information and start also to use the same technology, not only those early implementers. I think this is really good to highlight. And also, I would like to echo with what Professor Diso said. There are barriers behind the implementation, and not all the actors are in this room. I think the procurement being really one of the headaches we've experienced while implementing, we need to consider those barriers and be prepared enough engaging the country team, as highlighted, to avoid there is a delay. Back to food procurement. I think food procurement, and I would like to echo what my brother said, Jeremiah. I think we need really to look at the negotiated prices after a certain volume, which should be a pooled one. And I remember Dr. Njeka mentioned something about the costs. It's very unfortunate to see that 10 years later, or after 10 years, we are still having a higher price with exports, while we should have a lower price based on the volume of what has been procured. I think this is something we should think about and start negotiating with this pooled procurement and the pooled volume. In a way, after 1 year, we can see the cost reduced. That's what I really want to highlight on these two projects, two components, sorry, pooled procurement and shelf life. Over.
Thank you. Thank you so much. Very good comments, and I think some of them have been touched on a bit, but I think it's important for us to learn from the lessons on the rollout of GeneXpert. I think everyone in this room is contributing towards a pooled procurement and making sure that we get towards the target price of $2.50 once we get to 7 million. But thank you so much for your comments. Do we have any additions from the room? Lucy? Thank you.
Just to follow up to what Mohammed said about making sure that the products are in the country by next year. I'm just wondering, before the end of the next year, I'm just wondering, in the event that country processes take the 6 months or longer that countries were mentioning as some of the potential barriers with their regulatory and approval processes, would it be, and also if countries are considering the staggered procurement, would it be possible for the next lot of those, all the reagents should be in as well by end of 20? I see Grania is nodding. Okay, thank you.
Yeah, I think, yeah, we've discussed that. I mean, there are timelines that we're working against, and unfortunately, some of those timelines we cannot push. So the procurement timeline is 2026. The implementation timeline is not necessarily 2026, but the procurement of the platforms in the country has to happen before the end of 2026, and that's one that's not very flexible. So, yeah. Do we have any other questions? We have a few minutes. Go on.
Okay. So I think I'll introduce Patricia, but there were in the breakout groups that I was involved in, and I think I've heard from other of our technical partners who were in your breakout rooms, that there was a common question around the timeline of a publicly available WHO document regarding this platform. And so Patricia's very kindly offered to come and tell us the answer, because I think this is one of those, like our procurement timelines, maybe a timeline that there isn't much flexibility on. But Patricia.
Hello, everyone. Getting towards the end of the day, but I'm still seeing smiles. That's good. So for the policy timeline, we will work to release a rapid communication or the consolidated guidelines as quickly as we can. Because of our processes around document development, review, objective input, and publication, we do not anticipate a publicly available publication before Q1 of next year. So we are working to try and get this released in the Q1 of next year. But I can't, some of those processes are outside of my control, so we will do all of we can to get that released. At the same time, I've had a couple of questions around the implementation package and the tools, particularly the training slides that could be used for virtual presentation or on-site delivery, some of the job aids as well, and some of the technical procedures that could be adapted in countries, as well as how WHO will consider updates to the diagnostic algorithm. So we will work again to get that implementation package and the associated tools out at the same time as the policy, so that countries have access to the practical tools along with the policy. When it comes to the diagnostic algorithm, we will also work to incorporate any changes into our operational handbook. And so that is the place for those that haven't seen the latest edition. Hopefully everyone has seen it. It was just published in August, and it now has a consolidated algorithm 1. And I just want to highlight this because there have been a couple of questions around how Plus Life would be considered and whether it would need to be a new technology box added to the algorithm next to Ultra, next to MolBio, next to TB Lamp, and the other options that are coming to market. And so I just want to highlight that at least for the moment, we have consolidated those. So please look at the operational handbook we have now, because we now have an MWRD algorithm 1. Since a lot of these molecular solutions lead to the same results, right? It's MTB detected, MTB not detected. There may be an indeterminate or a trace result depending on the test. There may be an unsuccessful error. So we have consolidated that. We also have consolidated the populations within that algorithm. So you assess an eligible person for whether they're an adult, whether they're a child, according to the WHO definitions, that's 10 or less, and then whether they are HIV positive or negative, and it guides you through how many samples to collect and what types of tests are eligible for that collection. This type of consolidation is something that we will work towards keeping unless there is some kind of very specific consideration around the performance of the near point of care tests that would lead to a different testing or clinical outcome around the use of that result. But for now, I think that's a good place to start with referencing and comparing the algorithms too. And then again, we're aiming for early 2026.
Thank you so much, Patricia. Do we have any last questions? I think one of the questions we have is if we have any additional feedback on the bundles from the countries. We've had from Nigeria. I think Uganda had mentioned the need for, 2 platforms for replacement. But are there any additional, is there any additional feedback on the bundles that have been proposed? Do they work in your setting, or if you needed to tweak them, how would you tweak them? Would like to hear that, those comments if you have any. Philippines, let's see. They might have, yeah, let's see. I don't know if Louis, so I think Al, you're still online. Can you hear me?
Yeah, I can
Sorry.
hear you. Can you hear me?
Yes, I can. Did you have any comments on the bundles?
Yeah, so based on our discussion with Patricia earlier today, we are actually proposing to have another bundle with 500 tests. This would be great, especially for our rural or remote areas. We will be implementing the TB NPOC. And possibly with the lower number of tests for each bundle, maybe we can add one more battery pack, especially since this is a remote setting and we expect frequent power interruptions in those areas. Over. Thank you.
So the bundle you're proposing is 500 tests, 2 mini docks, 1 thermolyze, and 2 battery packs. Is that correct?
Yeah, that would be good.
Okay, thank you.
Does this smaller bundle resonate with others is a question, because I think I remember hearing it. I'm not sure where I heard it because I was going around different teams, but does this smaller bundle of less tests with the same number, you're asking for more machines, same number of tests, but yeah, okay. So that's Nigeria saying yes to 500, 2, 1, and a battery, 2, 2, 2. Is there anyone else? Okay, we have a Kenya. Is there a microphone? Yeah. Oh, you are comparing. Sorry. Okay. Okay, sorry. Please repeat that.
Yes,
Sorry.
Professor Jolova.
I'm sorry.
Bando, during discussion, I learned some very good things. Is it possible for each pilot to have 1 or 2 solar panels for the non-electricity thing? Then the other one is it also possible for an early release of some of the units to the NTRL to prepare ahead of the bigger release? Because otherwise, if you the bigger release and we are all learning at the same time, that may not accelerate things. And I've also been enjoying the manual here. Can you also allow us to comment on this money from a practical point of view? Thank you very much.
Thank you. Thank you.
Thank you. Maybe mine is technical. For Anyone who can tell us the package, the quantity in a pack?
The tests?
Quantity for the test.
There are 10 tests in a pack.
Oh, okay, great.
Yeah, and we also shared a lot of this information in the FAQ document that we shared. So just encouraging you to go back and read some of that information as well. Great, thank you, Professor Joloba. Really important points you've raised around, especially the NTRL engagement, and I hope it's something that other countries are thinking of and planning for how we can make sure the lab is familiar with the test before it's rolled out to other sites is really critical. If we have nothing critical or else, Jean Dedu, go ahead.
Yes, thank you very much. Thank you. I have one critical, which is a catalyzer. And I think the subject of this meeting was a catalyzer. So, and behind the catalyzer, I'm thinking of technical assistance. I think this is a component without which we cannot be successful. I think today we have discussed this funding, procurement, technical assistance, and M&E to measure the impact of this technology on the field. My main question is the following. I refer to one of the slides presented by Granny, I think, about TAs. And I would like to, you clarify, you think about the best way this TA can be coordinated to avoid it is fragmented. I'm saying that because within the African region, we succeeded and we have evidence showing that technical assistance, which has been coordinated through the TB supranational reference lab network, brought good results. And I think the Global Fund has been really funding through this network, and we have evidence on the continent. I would like really to highlight. And these really brought, let's say, good indicators in terms of the way TB is reported in the African region. So I would like really, you might not, or you have discussed this before, we consider not reinventing the wheel of the TA, but really using the SRL network model in terms of speeding up this process of implementation to make sure that we save our time and we go beyond the barriers. So this is a question and also a suggestion in case this has been discussed, the role of the SRL network in this particular TA coordination. Over.
Thank you, Jean. And I think there's the TA component is still the exact mechanisms of some components of it are being defined. So that is a very useful and timely comment. But I think from the participants today, I think the bit that is very much confirmed and is an important sort of time pressure is the embedded TA within the program. And so that is, and then the sort of elements outside that, we will continue to communicate with you, as well as you saw from the algorithm this morning, there is a Global Fund Secretariat coordinator, and I think bringing together not just as within the Secretariat, I was brought up that you and we are representing teams of people. So poor Mo is representing the whole GMD. So GMD. Oh, sorry, yes. Apologies. But we were unable to bring the whole Global Health Campus with us, but I think we have a lot of the Global Fund GMD colleagues, sourcing colleagues, technical assistance colleagues, as Melanie was saying, our CRG colleagues are all treating this as a priority. And so that needs coordination and linking with you and your embedded TA and our partners who've all come here to help support. So yeah, so I think that just the TA will continue to evolve as this process goes. But for right now, the important thing is that we work with you to get the right TA embedded in your program to support the hands-on work. Thank you, Jean.
Thank you, Grania. I think we'll start to wrap up now, and I will call on Mohammed to mention the next steps for this before we have our closing remarks.
You can get enough of me, I know, but I think it's important that you get the sort of roadmap on the coming period laid out clearly and with clear timelines also. So where do we go from here? Now that you have had that chance to explain to us your plans and to also hear from the team here, the offer that we are putting on the table, and engage in discussions with the partners about the technicalities of that introduction. I think you have a good overview of information that you can get back to your country stakeholders, obviously your country team members from the Global Fund, and to have conversations so that we can move forward on this. Now, moving forward, meaning that first, we got an important feedback from you on the need for different bundle, more for the decentralized testing level, and that would be with lower number of tests, more number of batteries. And we will work with our sourcing colleagues to estimate the cost for this. Hopefully, it will not going to change the budgeting that we have worked with, which is the $7. And once we get the confirmation to this before the end of this month, we will share with you a revised demand template that includes the additional bundle. Now, during that period, please don't wait for the revised demand template. Start your conversations, start having the discussions with the country team about the budget in anticipation of the bundles that you have now, with the anticipation that you'll get that additional bundle, and the costs that you might have to budget for aside from the product cost. So anything that relates to training, relates to policy guidelines, updates, change management, job aids, whatever you need for the in-country introduction, you'll have to budget for that. And we saw some of you have already done a good work, very good work on this in your country introduction plans yesterday. Now, by the end of the first week of November, we expect that you would come back to us with your revised demand based on the additional bundle. So there will be a communication from your country teams requesting this, with the revised template being communicated to you. And then we expect that you collaboratively work with the country team members to submit their revised demand. This would help us to finalize the volumes, the calculations on our end of how much it will cost to be able to support you with the volumes that you've communicated. Some countries might not take the offer, so please let us know this as well, so that we can reallocate those volumes that were initially allocated to your countries to other countries who are really willing to take them and want to move with the right speed for this introduction. So this is also another very important point to take into account, that we need to know from you as soon as possible if you are on board, if you would like to be part of this initiative, and you will have the commitments that it takes in order to move forward with the right speed. We will send you then a final official offer letter from your country team. Again, the fund portfolio manager or the country team working with you will send you that letter, which includes the final volume and the expected budget on the product that you will have to budget within your grant. And in addition to this, we'll provide you some information about the product that you have asked for here in an annex for that offer letter, which will help you with answering some of the questions about the products that you had. We'll also expect from you this not working business as usual, again, as I mentioned, in terms of getting the registration waivers or getting the accepting the lower than standard shelf life, if that's end up to be the case, because the supplier will be producing every month an amount, and based on your delivery plan, you will be able to get fresh production or maybe 1 or 2 months less than the 13 months that were announced. So that's something also to take into account. Now, if you have, and you will have a lot of questions during this period, so who to go to? So please reach out to the central team here, whom you all have their contacts, but also make sure to keep your country team members in copy and keep them engaged. So all the communications have to keep the country teams engaged, because the decisions about the budgeting and the grant comes, as Professor mentioned here, with those stakeholders involving the country team and the country implementers. So I think with that, we have clarity in terms of where we are going from here. What are the next steps? What are the timelines for these next steps? What are the expectations on your side, but also on our side? So I leave it here, and I don't know if we take some questions or we move to the closure.
Is there any final questions?
Any final questions, comments on these timelines, next steps, or everything is clear? I'll be very happy. Looks like it's clear. Yeah. Yeah. So Amina has a very good point that in case you already have the template ready and you don't expect that you will need that additional bundle because this came from few countries, but if you're happy with the bundles that you have and you have your template ready, please share it with us as well. Even if at a later stage, you will have that chance to do an iteration. It will help us again in the discussion with the supplier because it gives us the visibility on the volumes which we need in the negotiation on the price. Okay.
Thank you. Thank you so much. At this point, I'd like to call Dr. Eliud Wandwalo to provide some closing remarks for us. Once again, we just want to thank you for your time these past 2 days and the dedicated effort to get this running. Thanks.
Yes, we can. People are sleeping. Yes, we can. Yes.
Yes, we can.
I want to repeat what Mohammed has been saying. This is not business as usual. We have 2 reasons to say this is not business as usual. First, it's not normal for Global Fund to be very proactive about a product, even before WHO guidelines. So it's not business as usual. That's number 1. Number 2, for the first time, we have a private donor, philanthropy, who is contributing money to the Global Fund specifically for TB. I've been in Global Fund for almost 13 years. I've not seen that. And we need to thank SIF. Zach is here. TB is not their portfolio. So this is the first time they're entering this space. And we think this will not be the last. You are here, 13 countries. You have been selected the chosen one. And I'm sure you will work hard to ensure not only SIF as a private donor comes to TB, but we have more private donor coming. But you will be the one to set that pace. So us as a Global Fund, we will push the boundary. It's not business as usual. We have a private sector, and we expect as well, you as a country, you go back and push the boundary. You shouldn't take normal processes because this is not normal. We want to make sure that this product goes to the people who are affected. We have seen a potential through this product to tap into the people or the market which we have not tapped before. Because despite having this other diagnostic tool for more than 10 years, we have only been able to test half, 50% of the patients. So that means probably we have reached a plateau with the current product we have. So this is a new class of product, and we think we'll be able to enter into new areas. So grab this opportunity. Make sure when you go back, you don't go through normal process. You know, do the workaround. Go to your leaders, talk to them. You know, inspire them. Tell them about the potential to be able to go lower and be able to get the people whom probably we don't get through the normal platforms. So I would like to use this opportunity to thank you for coming. For us, this was invitation to look at whether there's an appetite for that. And you have confirmed what we suspected, that you also think this is an opportunity, and you have confirmed that you will be in this class, the selected few countries for this initiative. There was a question about the bottlenecks probably coming from Global Fund. This is a joint effort within Global Fund. It's led by our executive director. He's actually pushing for this. So it's a priority within Global Fund. And as you can, it was said, all the teams are working with this. We have a joint working group which comprises all the important department and people. So I want to assure you that this is a priority also from the Global Fund. Actually, at the beginning of November, we are going to present to our executive director and our senior management the outcome of this workshop. And for them, I think they take this as a priority initiative. So you have the full support of the Global Fund, and we'll make sure that we work with you to accelerate the timelines. I think time is of essence here, and the timelines are very ambitious. And this year has shown anything is possible. Anything is possible, you know? And I think we can demonstrate by introducing this product that anything is possible. I've been in TB area for many years, and one of the challenge we've been having in TB, I think we want perfection when it comes to anything. We want to have the perfect product. We have to have perfect timing. We want to have everything perfect. And that has been a bottleneck in TB. When it comes to other diseases, malaria, HIV, whenever they have a product, whether it's imperfect, they will put a lot of advocacy around it. And I think we should have that attitude as well. You know, perfection should not be the enemy of good. We have some limitation, yes, with this product, but we should also look at the benefit we are getting with this product. So it will be up to us, and that's why we are expert. That's why we are trusted by our community to overcome those challenges. We shouldn't be bogged down with challenges. I think our work is to go around the challenges. We should always think about the patient, that how do we make sure that person down there get this product? So yes, it's good to talk about these challenges, but I think we should talk about challenges with the aim of finding workarounds. And we are here, all of us, in our different capacities, ability. We have professors here, Jolobas, and others. Let's use this brain power. Let's use this brain power. We have WHO, Patricia is here. You have Global Fund. We have country team. So I'm sure if we work collectively, we'll be able to beat any kind of challenge. So don't be bogged down with the challenges. Look at how we can solve these challenges. We have a network now. Be free, write to anyone. We have brains here. and we should be able to overcome those challenges. So I would like to encourage you to go out thinking that we'll have this product first quarter 2026. That's our aim. And Patricia has assured us that WHO will make sure every document, policy, guideline, they come together. It's, and she didn't say, she said by January, was it January or, you know, yeah, I heard some, but everyone will work to make sure you have the tools you need, you have the money, you know, you have everything. So for me, I see that the stars are aligning because this is the price you are getting is subsidized, you know, it's a subsidized price. So I think everything is within our capacity. Everything is within our, I don't see anything which is outside our capacity. If people can go to the moon, can go to this, you know, other stars, you know, we will be able to bring these products to our villages. They are accessible, you know. Voyage, I was reading about this voyage. It has traveled now 6 billion kilometers. 6 billion, not million, billion. So people can reach unreachable. So I'm sure we'll be able to reach our villages. We go to our villages. We'll be able to bring this product to our village. It's possible. So I would like to thank our team who has worked very hard to make sure that we have this workshop, and you will agree with me that it was very well planned. It's 2 compacted days, but I think everyone has worked to make sure that we have this workshop very well organized. We have very good product out of this workshop, and I'm sure from now, the work has started. We have not finished. The work has started from now. So I would like to thank the team. Grania has been leading this team, and others from Global Fund, Amina, Melanie, Mohammed, Obat, who else? Yeah, everyone from the Global Fund who has worked, Massini, of course, who have worked so hard to make sure that we have this meeting. Also, I would like to thank our partners whom we've been working together to make sure that that you have everything you want. WHO, Stop TB, United, Chai, Gates, of course. Gates, how can I forget Gates, who have really negotiated this product and ensure that we have it. I don't want to stand between you and enriching the economy of Nairobi. I was told you need to go out and make sure that you contribute to the economy of this great country. And of course, I would like to thank our ACLM colleagues who have really worked with us to put together this workshop. So for us at the Global Fund, the work has started. We started before, but for us, we take this is a marching order that we are going to work with you. We assure you our full commitment to ensure that this product is available very early to the villages, because that's where we are aiming. And next year, 2026, for us is a starting, but we are also looking at GC8, where we think countries will use that opportunity to scale up this product and be available throughout the country. So thank you very much, and wish you, I'm sure many of you will be staying for the coming meeting, so I wish you a good meeting. For me, I will be traveling today back to Geneva. Thank you so much.
Thank you so much, Eliud, for that inspiring speech, really. I hope we're all inspired to not do business as usual. I'd like to thank you, but once again, thank ASLM for the wonderful organization of this meeting. Let's please put our hands together for the team that has behind all of this. I would like to thank the translators for working so tirelessly. And I'd like to thank you all for the 2 days that have been very productive. And as Eliud has said, the journey is just beginning and we're all in this together. For those of you who are traveling tomorrow, we wish you safe travels. We've sent out an email regarding your pickup times. And those who are staying on for the ASLM meeting, we'll see you as the week proceeds. For now, we'll close the meeting. Thank you all and go out and enjoy Nairobi.